as I share this. Everyone can still see my screen, hear me okay. Awesome. That's always a good sign. So we are just jumping right back into where we left off. I know that we got through anatomy and physiology last time, and we got, I think, to oxygen with our pharmacology. So we're going to do a little bit of review just to start, because I know we went through a lot before we even got here last time. So we'll just make sure we touch on the big points, review a little bit of nitro, and get going. So again, we're going to be covering a lot of different parts of our human home throughout pharmacology. We have a lot of medications that affect a lot of different parts of the body. So just in general, we are going to be talking about quite a few systems and structures that relate to that anatomy and physiology that we talked about. But more so, we're going to be talking about a little bit deeper into it, a little bit more about like the chemicals, the molecule side of it. Not super sciencey, but that's kind of the area that we're going into. Small picture with medicine, brought out to big picture for signs and symptoms that we're hoping to see in our patients or not hoping. So we're going to be responsible for administering these medications. And if we do this incorrectly, there is a chance that we could really harm our patient to the point of death, not just increasing their sickness, but leading it to the point where we could actually trace it back to say, this is our fault that the patient ended up dying. So this is one of those topics definitely want to pay attention to, and we're going to be reviewing a whole bunch. This is one of the more important topics for us to really have down as EMTs. So another thing to remember, anytime you're going to consider giving a medication, just remember that once you give it, you can't take it back. Okay, you can't have them throw it up. That's not how it works a lot of the time. If you give a medication that a patient doesn't need, it's permanent. We are going to be talking about pharmacology in general, which is just the main broad term of study of effects in drugs and medications. Some of the other vocab, we're going to be mentioning agonists, which are a type of medication that are going to stimulate a response, or they stimulate the receptors, whereas an antagonist is going to block and bind other receptors, stop them from being stimulated. They take all of them. And then just a review of the different routes, right? We've got intravenous, which is into a vein, not within your scope of practice. Uses needles that look like this. They range from very, very tiny to very, very large. This 14 gauge IV is nicknamed the garden hose. It's pretty rare that we actually administer anything through 14 gauge. That patient really needs a lot of quick fluids. If we are considering a 14 gauge, it means they have already lost a lot of blood. They need a wide bore to get it in. Whereas something like on this end, right, upwards of 20 gauges, this pink one here, it's going to be more for either pediatric patients or patients who have really small veins, or for specific medications that need a little bit to go in. We have interosseous, which is into our bone. So we actually drill a metal catheter into somebody's bone, where then we can put medications into their bone marrow, which is connected to the circulatory system. We only do this in really intense moments where somebody needs medications quickly, and the fact that we can't get an IV is pretty prominent. So for the most part, these are used by advanced providers in cardiac arrests, but they can be used in other life-saving situations like severe hypoglycemia, where the patient isn't able to get an IV to get blood sugar, or glucagon isn't working, or something like that. Oral medications, pretty straightforward. We put them into our mouth. We either just swallow or chew them, and they get broken down in our stomach, and that's how the medication gets out to our body. Versus a sublingual medication, which will sit underneath the tongue and dissolve, and that's how that medication gets into the bloodstream that way. While they both involve the oral cavity, oral medications really are about the medications that we intake down into our stomach, and that's where the medication gets broken down. Whereas sublingual is through the mucous membranes of our mouth, and it kind of dissolves through the floor of our mouth there. Inhalation is just how it sounds. Any medication that is input through the lungs. So this has a pretty quick absorption rate. So medications that are inhaled, besides IV injection, this is one of the fastest ways to get medications into the body. So oxygen, albuterol, things like that we're going to be talking about, definitely inhaled medications. Sub-Q or subcutaneous, that is the shot that goes underneath the skin, but not deep enough to go into the muscle. So very commonly diabetics inject insulin this way. But The more common one out of these two is going to be intramuscular. Also have intranasal, which is one that you guys will be able to do. This is for Narcan. It's when a medication is atomized or turned into a spray, a finer mist, and you actually spray it up somebody's nose, and the mucous membranes, the permeable stuff up in here is what actually accepts that medication, gets it into the bloodstream. Intramuscular is just standard shot, right? You go to the doctor throughout your life, you probably got some intramuscular shots right in your arm. It's where vaccines and just kind of general medications will go if they need to be inserted through a needle. This is what we can give epinephrine through, whether it's through an auto injector like an EpiPen, or in the state of Vermont, we have the Ready Check Inject program. So you will learn actually how to draw up epinephrine out of a vial and inject it into somebody's arm like this. And then finally, for our purposes, we have per rectum. So that is a medication that goes anally. The only medication that we do this with is this rectal diazepam for patients who are prescribed it. This is usually for pediatric patients or for people who need a quick way that they can't necessarily get IVs or anything like that to stop seizures. So this is a benzodiazepine. And the whole point is if somebody's seizures are not stopping, they're prescribed this medication, we can assist it with them or assist them with it. So pretty straightforward, goes right up the rectum, push the gel into it, and that medication will be absorbed that way. That's also a very quick way of getting medications into the body. So for your purposes, these ones with the checks, again, are the ones that you will be responsible for knowing. Not only just what medications we can give that way, but then also how it's appropriate to give somebody this medication. So that goes along with these 5 rights of medication administration. So we need to know the route in order to have it as one of our 5 rights. So every patient that we're going to consider giving medications to, we need to make sure that we have these 5 rights. So the right patient would mean that if we're assisting somebody with their prescribed medication, we are not just substituting somebody else's prescribed medication. So we're on scene for a wife of a husband who is prescribed nitro. She's having chest pain. We're not going to take his nitro and assist her with it. We need to make sure it's the right medication, right? We're not going to give somebody who needs aspirin, albuterol, because they both start with A's. We need to know which medication that we're giving, the right route, how it gets into the body, how much we're going to give. And then for this case, right time is pretty much whether or not the medication is expired. So we want to check on that bottle or check on whatever it is that we're giving to make sure the medication is within date. And then we also want to make sure that there's no contraindications about doses and how much time needs to be in between. Right. So we talked about nitro a little bit last time and how we're going to give 0.4 every 3 to 5 minutes while some symptoms persist and they don't have any other contraindications. So that's one of those things. Okay, has it been within that time slot? Are we within our ability to give them another one? So these 5 rights, definitely something to have down. And then what we talk about with each medication, so not only just the 5 rights, but how we can get to know if it's the right medication, is all of these things. So we're going to need to know for all of the medications that we have within our scope of practice, we need to know its indications, the reasons we're going to give it, its contraindications, which is reasons that the patient tells us or from their signs and symptoms, we think they need this medication. They would benefit from it, but what are the reasons that we should not give it? So there are going to be times where we say, we think you need this medication, but due to these signs and symptoms you're exhibiting, we cannot give it to you. It would not be safe. Dose, how much to give. We're not just going to kind of throw a handful of medications at somebody, say, open up, right? Whatever you catch in your mouth, that's the dose. That is very wrong. We're going to know exactly how much to give, usually in milligrams or a set number. We need to know how it gets in the body appropriately. We're not going to give albuterol IV. We're not going to give nitro orally. We're not going to give aspirin intranasally, all that kind of stuff. And then actions and side effects, that's what we need to know about how the drug interacts with the body, what response we're looking for, what's our hopeful response, right? Like what are we trying to exhibit with the patient? What are we trying to help them with? And then also we need to register that those side effects are definitely part of that action. They're not necessarily a mistake. They are just part of what that medication does. Hopefully the patient won't experience anything that's super uncomfortable or negative for them in this way, but we do have to register that it could happen. And so if we see it, we need to register, okay, is it normal or is it abnormal? So we can skip over my Oxford treatment of side effects, just kind of went over it. Remember, it's just the actions of the medication. It's not a mistake. It was just deemed acceptable by statistics. It is a potential, all side effects potential to happen when we administer somebody this medication.
Can I ask a question real quick?
Absolutely.
Oh, that just came up. I was going to ask that same question that Matt just asked. Do you let the patient know the possible side effects prior to giving them the medication?
If they ask, it's a great thing. You can do that. It's not required to. You don't have to say, okay, I'm giving you nitro. This is what the possible side effects are. If you want it to be super thorough, that's a really great thing to do, but it's not necessarily required. If a patient asks, go ahead and tell them. But for the most part, it's so that when we give the patient the medication, if they're like, hey, you just gave me that nitro under my tongue, I'm kind of feeling a little bit of a headache and my tongue is kind of tingly, you can say, you know what, that's actually a side effect, completely normal. Or, somebody you just give epi to, they're like, hey, my heart's beating really fast. I'm breathing a little bit better, but I kind of feel jittery. And you're like, well, you know what? That's actually a really good sign. It means the medication's working. Epinephrine is just adrenaline. I gave you a fake adrenaline rush. So like, it's going to feel kind of wonky for a little bit. Take some deep breaths. I'm here for you. Yeah, great question. So these are the medications for the most part that you guys will need to know. We do have activated charcoal up here, which we'll talk about, but just so you guys are aware, this is no longer a responsibility of yours in the state of Vermont, and we'll talk about why when we get there. But everything else, oxygen, oral glucose, aspirin, Tylenol or acetaminophen, Narcan, epinephrine, albuterol, and nitroglycerin. These are some big ones that we're going to have to know. These are all the medications you will be, responsible for. So we can skip over this fun video and just review nitro really fast. So nitroglycerin, this is that big kind of dangerous one that if we're going to talk about dangerous medications that we can give, this is by far the most dangerous. We give it to help with cardiac chest pain. So not just any sort of pain that's happening in the chest. We need to do that assessment to determine, okay, we think this is cardiac in nature. Something is hurting the heart. The heart is causing that pain in your chest, not the structures around the heart. It is specifically due to a potential partial or full blockage of one of those arteries or veins in the heart. Now, the danger is really why we want to focus on these contraindications. Indications for nitro, pretty straightforward, right? You are prescribed nitroglycerin because you have a heart condition. You take it when you have angina or heart pain. You may have had a heart attack before. Okay, great. That's a pretty good indication. But this is when we need to do a very thorough assessment to make sure that we're not going to give this to somebody and cause an issue, right? So we need to make sure that their systolic blood pressure is above 100. So we got confused last time. It's a contraindication if the systolic blood pressure is below 100. So it needs to be above that 100 systolic. They can't have already taken 3 pills of nitroglycerin, 0.4 milligrams that day, or they cannot have taken a sexually enhancing drug within 48 hours. And those are just some listed examples. And just a reminder, we need to ask every single patient that we are going to give this medication to these questions. If we omit these questions because we just don't think that there's a possibility that this 87-year-old Mima is taking sexually enhancing drugs, we could end up with a bad, unresponsive patient, right? So we need.
What if the patient took the drugs but does not tell us that at all during transport or anything?
So if you ask them, hey, did you take sexually enhancing drugs? And they say no, that's an issue. That's one of those times where that's kind of, that's a tough one. You wouldn't be at fault if they said no.
Yep.
But that's why if you're suspecting it all, or if you're going to have to look at them, if somebody ever says to you, when you're asking an uncomfortable question, like, have you taken sexually enhancing drugs? And they're like, no. Right. I'm going to be like, are you sure? And then you can pull a Keanu Reeves and be like, well, just so you know, I want to give you nitro. And if you have taken sexually enhancing drugs, this could be fatal, right? This could be really bad. I am asking for your safety. I'm not going to tell anybody. I don't personally care. You can do whatever you want in your bedroom. But if I give you this medication because I think you need it and you've taken this drug, you could die. And that usually will get people to say, oh, yep, absolutely. I took Viagra.
Are there any non-prescribed medications that can be contraindications as well? Like, is there any, like if somebody's using other stuff, is there anything else that we should be aware of?
Non-prescribed medications, not that I can think of.
Okay.
It's really just that vasodilation of those medications, the sexually enhancing drugs, is so similar to nitro and they respond to each other.
Okay.
Yeah, there's nothing else major for us to worry about. So those are the contraindications. We need to ask every single one of our patients those questions if we're going to consider giving them nitroglycerin. The other thing about nitro, I'm not sure if I mentioned this last time, it is the main component of dynamite. So if for some reason you were to set a nitroglycerin pill on fire, it would probably go boom. So we want to make sure that we are careful with these. They come in two different forms. We've got the spray, which is this red bottle up at the top of the screen. And then we have the tablets down here. These tablets need to be kept out of direct sunlight. That's kind of why they're in this brown bottle. A lot of times you'll see nitro in an ambulance, like wrapped up in a gauze pad to really just keep it in a nice dark place. If it's left out in the sun, it could degrade and become bad. So we also just want to make sure we're checking the storage. If we're going to assist somebody with their own nitro, if they haven't taken it in months and it's just been sitting on their windowsill in direct sunlight, we probably should not give it to them. But the dose per pill is 0. Yo.
I just had a quick question on administration.
Sure.
It wasn't clear to me if this was something where we were only allowed to help a patient administer their own medicine, or whether this was something where we could administer it independent of an existing prescription.
Yeah, great question. So for you guys, National Registry says you are only able to assist somebody who is prescribed this medication. So advanced EMTs and above, we have this on the ambulance and we can give it to people who we think, even if they're not prescribed it. But for you, you can only assist somebody who has nitroglycerin prescribed to them. So that actually kind of makes it a little bit easier for you, right? If you go to a scene and it's just you and somebody says, I'm not prescribed nitro, but I'm having really bad chest pain, out the window for you, right? You can call advanced EMTs or paramedics to come and help, but you don't even have to worry about it. So if they're not prescribed it, you can't even consider giving it to them. The other thing we want to consider, if you're practicing within District 3, calling medical control before giving nitroglycerin, definitely very important, especially if you are the sole provider as a basic EMT. You need to call medical control to verify that it's all set. Besides that, we can give up to 3 tablets, 3 to 5 minutes apart, and that's only if the pain is persisting. So just because we can give up to these 3 medications or these 3 doses, we don't need to. It is just based off of how the patient is feeling. So if they've got a 10 out of 10 chest pain, they don't meet any contraindications, you assist them with their first pill. Their pain is still 10 out of 10, 3 to 5 minutes later, you can assist another one as long as their blood pressure is still good. And then say after that second one, their pain goes down to around 5 out of 10. I'd say that's pretty good. We have helped their pain. They don't need that 3rd dose. They still might have a little bit of discomfort, but we took them from that 10 out of 10 pain down to a 5. I'd say we're pretty good. We don't need to push it anymore. We're just going to help them alleviate their pain symptoms a little bit. So that's when nitro is kind of weird, right? Like what we're giving it for is to help with chest pain. And we've talked about this a little bit before, but there's actually in patients who are having chest pain due to cardiac related things. So like a heart attack, it is when a clot is blocking blood from getting to the heart. There's actually not a whole lot of data to show that nitroglycerin, it helps with people surviving heart attacks. What it does is it really helps with that pain. In combination with aspirin, aspirin is definitely shown to help people survive heart attacks and partial blocks. So in combination, these two medications do wonders together. But nitro, for our purposes, is really to help alleviate chest pain, not necessarily to help somebody with their cardiac event. So out of the two medications, and we're going to talk about aspirin later, somebody's having that chest pain and you think it's due to a cardiac related event, aspirin should always be your first go-to. One, there are plenty of, aspirin has few contraindications, so it's very easy to give to people. And a lot of people take it already. It's a very safe drug to give, and it really helps in these situations. Whereas nitro can kind of be like okay, I've given aspirin, they're in a lot of pain. I can help with this, right? They're not meeting any contraindications. I'll give a call to medical control. They're in a lot of pain. Aspirin's on board already. Let's see if I can give them a nitro, help them with that pain. Okay, so out of the two, aspirin should always be your go-to, but nitro definitely something that can help these patients if they're prescribed it. We give this one under the tongue. So that's the one that dissolves through the mucous membranes. So if you're going to give somebody the pill, make sure that you have them keep it underneath their tongue. It's not one that you put in your mouth, chew and swallow. It needs to stay under their tongue and dissolve. If you're going to give the spray, you just have them lift up their tongue and you do 1 spritz equals 1 pill. So 1 squirt of that medication equals 0.4 milligrams. So that is 1 dose. The actions of this medication: severe vasodilator. It makes veins go from small to big very quickly. And so that vaso is going to come into play, recognize that as veins, and then dilator really just makes bigger, right? If our pupils are dilating, they get bigger. And then the side effects that we're worried about with nitro is that severe hypotension, right? If they have a negative response to it, or maybe they did take a sexually enhancing drug and didn't tell us, or we didn't ask, it could plummet their blood pressure to really low depths, which, if we talked about shock, can tell you that they're not perfusing well enough to, continue life. So it could be really dangerous for these people. We are looking for the action of vasodilation, but one of the side effects is severe vasodilation or hypotension, right? It can make somebody's blood pressure plummet. Pretty common and not so worrying side effects that we see here are also a little bit of a headache. That's what the HA is. And then some tingling under the tongue. That's just from the medication making its way through the mucous membranes, can cause a little tingly. Another thing.
Does the person need to be sitting down in order to administer this?
No, not necessarily. I would recommend that you administer it while they're sitting down. I mean, it's just pretty easy getting them on the stretcher and stuff, but it's not necessary. It's not one of those things that needs to happen.
I had a patient in a different clinical setting who walked out of the clinic and then came back in and was having a heart attack and had taken, actually he took 2 nitro pills and put them under his tongue, but he was severely dehydrated, so they weren't breaking down. So I don't know, like, if there's something you do in that situation to help, or no.
If they aren't able to break down the pill, again, I'm going to say nitro isn't going to save your life. If you can deal with the pain for the 20 minutes max it takes up to get to the hospital, that's the priority.
Okay.
Okay. But yeah, that's a challenge, right? If they don't have enough mucus to break it down, or they don't have enough saliva, they're not going to be able to take the medication. Because also, we don't want to give them anything to drink. We're not really allowed to give them any food or water in the back of the ambulance. So it's one of those things. Yeah, great question though.
So at that point, would you leave it in there, or would you have them take it out?
Personally, I'd probably have him take it out, especially if he took more than we're allotted to give in one time. I'd say, that could be kind of a danger. Hey man, spit those out. I'm going to call med control, see if they think anything got in there, and then I'm going to finish you off with a dose of aspirin, right? I think that's what's more important for you if you're having a heart attack than the 2 nitros.
Hold on. So if someone is, let's say, severely dehydrated, you're not allowed to give them water?
Yeah, not by mouth. If someone's severely let me clarify. So if somebody is calling you for severe dehydration, give them water, or call advanced EMTs to give them IV water. But if someone's calling you for a heart attack and they're also dehydrated, we're not going to have them drink anything or eat anything, because if they need surgery, that can be an issue. If they're going to throw up and they're going to aspirate whatever we just gave them, that's kind of a bad deal. So if you're treating somebody, their main medical concern is dehydration, That is a different thing than like saying they're in shock or having a heart attack. Yes, you can give them something to drink. If they're having heat stroke, give them Gatorade, give them water, cool them down. Absolutely. But if someone you think is having a heart attack, they don't need to take nitro. They need to get to the hospital to have surgery. So they need their stomach to be as empty as possible.
But if we're going to be giving them aspirin, is it liquid aspirin we're giving him?
Chewable.
They're going to, oh, it's chewable. Okay.
Yeah. Yeah, so that's part of the reason why we carry chewable aspirin is because we don't want any medications that need to be washed down.
Gotcha.
So we can mitigate it a little bit, right? Yeah, I know your mouth is really dry. I'm sorry, but chew on these pills, like swallow as much as you can,
Right.
versus try to break down these 2 extra nitros with nothing in there. Aspirin will do more good than that nitro.
Okay. Thanks.
Yeah, great questions though, everyone. So some ways that we can assess for cardiac chest pain. Remember, for aspirin and nitro, it needs to be confirmed, or essentially we need to be beyond a suspicion of a doubt that they have cardiac related chest pain. So the ways that we can assess for that is if there isn't pain when we touch the area of their chest around their heart that they're saying is hurting, that it means it's potentially cardiac, right? But if I'm palpating here and I'm palpating the muscles and the bones and they say, ow, that can tell us, you know what, I don't think this is cardiac. I think this is musculoskeletal, right? Something I can palpate, something hurts when I touch it. If we listen to the lung sounds with a stethoscope, if it's normal lung sounds or maybe a little wet lung sounds, that has a potential to be cardiac. But the main thing that we want to be concerned of here is that if it's diminished lung sounds on one side and it's the side that they're having chest pain on, that could be a respiratory issue. That could be a lung issue and not cardiac, right? So if somebody has, say, a hemothorax, right, they have some bleeding inside their lung cavity and it's compressing their lung, and we say, you're having chest pain, here, take this nitro, it's a vasodilator, it's going to open up all your vessels, and they're bleeding into their chest, it's going to increase the speed at which they die. Essentially, you will increase the speed at which they are losing blood into their chest cavity. So, but if we listen to their lung sounds and we determine, hey, you know what, I can't hear any air going into their lower right lobe of their lung, I think this is a lung issue versus a heart issue, no nitro, right? That's part of our assessment. The other thorough assessments we can do is getting familiar with the type of pain that cardiac kind of presents as. So people who are having cardiac pain typically don't say that it's like a sharp or a stabbing pain. They tend to say it's a pressure, a crushing, like a weight on my chest. It feels like I'm just being sat on by an elephant, versus something that's like sharp or stabbing can lead us to think something else. You know, if they have a history of angina or a heart attack, a myocardial infarction, and they are prescribed nitroglycerin, that's a pretty good way to assess. Hey, has this happened to you before? Yes, you've had a heart attack and you were prescribed nitro. How does this feel compared to that other time? And they say, it feels exactly like the time I had a heart attack. That's some pretty good history taking. You know what? I trust you. You're prescribed nitro. Let's check your vital signs and make sure I can give you some, because I think you would feel better if we did. And then also, right, if we take an EKG and it says that they're having a STEMI, we can say definitely cardiac, right? Let's give them some nitro if they meet the indications. So again, the whole purpose that we're giving nitro, because I remember when I was in EMT class and I heard somebody say, we give nitro, but like it doesn't save anybody's life and like it's super dangerous. So like I was kind of thinking, okay, so then why do we even give it? But it does help with that pain, because if the artery is blocked or a vein is blocked by a clot in the heart, right, all of this oxygen bearing blood is the only part that's getting there. And usually, you know, we have a whole vessel's worth, and that's why our heart isn't in pain. It's getting the oxygen it needs. It's not letting off any of those signals. But if we've got a blockage like this, that's what's going to lead to the pain. The heart is actually suffocating. It's starving for oxygen. So heart muscle's having a hard time to breathe. But if we give the nitro, what we're going to do is open up that vessel, hopefully around the clot, not doing anything to the clot itself, but allowing more oxygen-rich blood to flow through to get to that muscle and to make sure that that pain is diminished. Now, it's not going to fix the issue, like I keep saying. It's just going to help with their pain, make them feel a little bit better. So dangerous, dangerous, dangerous. I said that all already. Remember, it's dangerous. Contraindications. Ask everyone if they take sexual enhancing drugs. Now, oxygen, pretty straightforward. If somebody's having difficulty breathing, if we think they're in shock, that hypoperfusion, if we think they're having cardiac chest pain, we should give them some oxygen. Their SpO2 will definitely help us determine if they need oxygen. So if their level is below 94, and definitely in conjunction with some other signs and symptoms, that'll tell us they need oxygen. Now, there isn't really any danger in short-term administration of oxygen. So for our patients, if we think they could benefit from oxygen, it's within our rights to give it to them. It should be okay, and you don't really have to worry about it hurting them. We will mention the drawbacks to long-term high-flow oxygen. Somebody who is on oxygen for a long period of time, days to weeks to months, that could lead to some issues. But personally, that's not really our issue, right? If we're giving somebody oxygen in the ambulance, it's because we think they need it. And if we get them to the hospital half an hour, 45 minutes later, the hospital says they don't need it, they will take them off of it. Oxygen is a really great tool. It will help people feel a lot better. You will be surprised at how quickly somebody's demeanor will change if they're hypoxic. They'll be short, they'll be snappy. You will think they are the biggest jerk in the world. You put an NRB on their face with some high flow oxygen, you get them the oxygen they need, and they will be so nice. It just changes people's demeanors if they are really suffering from that hypoxia. Dose is also kind of a tricky one here. We can give oxygen through a bunch of different devices, and each of those devices has a regular flow rate or how much it can take. So for a nasal cannula, one of the 2-prong little tiny tubes that you tend to see in like classic hospital shows, everyone sits there with a nasal cannula. Those are low flow, kind of more supplementary oxygen devices. They can handle between 1 and 6 liters per minute, but we tend to give patients 2 to 4 liters per minute through a nasal cannula, just because that's really the therapeutic range. Like 1 liter per minute might help a little bit, but that's going to be more for people who are on at-home oxygen, who might need just a little bit. And then 6 liters per minute, like on a nasal cannula, will just be really uncomfortable for that patient. So 2 to 4 usually what we use for a nasal cannula. If we're going to use an NRB or like a BVM, one of the big high flow oxygen devices, we will use 10 to 15 liters. That is what we consider high flow oxygen. That's going to be incredibly important for anybody we consider a high priority patient. People who are in shock, major trauma, cardiac arrest, whatever. Anybody who needs a lot of oxygen, 10 to 15 liters per minute. If they're able to breathe on their own, that's when we give them the mask. The non-rebreather mask has the inflatable bag. And if they are not able to breathe effectively on their own, that's when we would do it for them using the BVM, using positive pressure ventilation. Root inhalation or positive pressure, really just getting the chemical into the lungs for them to do their job, for them to suck out the oxygen, push out the carbon dioxide, and get us to breathe it out. Actions of this one, not very complex. It increases blood oxygen levels. It reduces strain on the respiratory and circulatory system. Essentially giving the body what it needs will just reduce the strain of it. And that's what the side effect is. It's kind of what we're looking for. And we'll just touch on handling oxygen. Remember, if we knock off the top of one of those bottles, it could become a projectile and go flying. We don't need to watch it again. And then also it is not necessarily an accelerant, but it will feed flames. It makes flames burn hotter and brighter. So we want to make sure that we are not administering oxygen around an open flame. And again, so many patients who call for difficulty breathing are smoking a cigarette when you arrive with an oxygen mask on their face, and it's very dangerous. I think that's where we stopped last time. So all of this is brand new. So this next one, oral glucose, is really great. This medication is one of those times where if you see somebody who needs it, and you are able to give it to them, you will see a major change in their demeanor within the next 15 minutes. So the reason we give oral glucose is for hypoglycemia, and that is the term for when our internal blood sugar is low. Specifically for our purposes, we can measure that blood sugar with a glucometer, with this little thing right here on the screen, and that involves cleaning the finger, actually pricking it with a little lancet, a little needle, and then using the drop of blood that we get from that to touch to a sensor stick, which then will give us a readout of the blood sugar.
Kevin,
Yeah.
at what point during your interaction with a patient do you end up measuring blood sugar?
That's a good question. And that's going to depend on how the patient is presenting. Hypoglycemia will usually make somebody altered. It'll make them confused. It's actually oftentimes hypoglycemia and being intoxicated on alcohol, being drunk, are oftentimes mixed up. So people who have hypoglycemia will be slurring, that might be added to this thing, and you're like, hey man, how much did you drink today? And they're like, I didn't drink anything, nothing at all. And you're like, okay, yeah, sure, right. Let's check a blood sugar. Let's see what's going on. You check it and their blood sugar is like 40. You're like, wow, you need some sugar. So it depends, if somebody is altered or they're unresponsive, this is probably one of the first things I'm going to do after their ABCs and all that kind of stuff. This is one of those things that can really tell us quickly what's going on. But, if I'm talking to a normal patient, they're conscious, alert, oriented ×3, it's going to be later on my list. And there are plenty of times where the patient, and I'm kind of at my wit's end, and I'm like, I have no idea what's going on. Let's check a finger stick. Maybe that's it, right? They're acting weird. I don't know what's going on. Maybe they're a little bit aggressive. Let's check the finger stick, see if it's wrong or see if it's off. So anytime somebody has altered mental status, this is going first, not first, but in the first priority of my list. Same thing with kind of assessing pupils. But if they're acting normal, they're not altered, we don't really have to check it. So specifically for hypoglycemia, if they're hyperglycemic, their blood sugar is really high, we will check it, and they might not be altered. But we'll talk about that when we get to talking about hyperglycemia. So, important thing for oral glucose. This has a big contraindication. Because we're giving this to people who we think might be altered or their level of consciousness might be diminished, we need to verify that they can control their own airway before we give it to them. This is an oral medication. It says it's in its name. So they need to put it into their mouth and swallow it. It is not enough to have it rub on gums or dissolve through mucous membranes like some medications. So if somebody is completely unresponsive, they're not able to follow commands, they can't prove to you that they can swallow and manage their own airway, we're not going to give it to them. If we introduce this to somebody's mouth who can't swallow, like we pour it into their mouth hoping it's going to help, they have the chance of suffocating because we are putting a foreign body into their airway, which they cannot control. Or they have a possibility of aspirating it. If they take a deep breath in, it could go into their lungs, not into their stomach, and that would be really bad. Oral glucose, you get it on your gloves and it sits there for more than 5 minutes, you will rip your gloves trying to get your fingers apart. It is just so sticky. So I can't even imagine what it would be like if somebody accidentally inhaled that into their lungs. It would be bad. So that is a
question.
Yeah.
So on our rig, we carry maple syrup.
I will get there.
Okay, perfect.
Great. That's a fun topic to talk about. So it's in my presentation, don't worry. So making sure that they can swallow, that they can manage their own airway, that is the major thing. So if we get to somebody, they're altered, we have reason to suspect that they have a low blood sugar, we check it and it's below 60. Then we can say, hey, give me, follow my commands. Hey, can you swallow for me? Show me that you swallow. It's as simple as that. Great. Yeah, I can swallow. Awesome. We're going to help you eat this whole entire packet. So it's 15 grams is the standard for sugar. And this is the one that kind of gets people kind of confused later on because majority of our medications are milligrams in dose, but this is food essentially. And medications, milligrams are super small. We want to give a little bit, whereas food, we can have them take grams, full grams. So the way that we give this, we check their finger stick, we make sure they can swallow. And if it's below 60, we'll give them the whole tube, 15 grams, and we'll wait around 15 minutes. That's when we're going to assess their blood sugar afterwards. Now, when we reassess or how long we wait is going to determine on how the patient is doing, right? Like if we give them the 15 grams and they continue to decline and go unresponsive, we're not going to wait the 15 minutes to reassess. We're going to say it's not working, let's get going. But if they're like kind of altered, we give them the 15 and we start to see them actually start coming around within 15 minutes. That's great. Let's hang out. We might not need to bring this person to the hospital. So 15 grams, wait 15 minutes, and then reassess that blood sugar. Now, this is another part where this can kind of get confusing, where it's when we assess for the first time on that blood sugar, if it's below 60, we give them medication. But on our reassessment, if it hasn't come up to above 80 after 15 minutes and 15 grams, we can consider giving another half tube to another full tube. But that's only if it hasn't broken 80 after reassessment. If they have gotten back to 80, we're not going to give them anything else because 80 is considered the minimum normal blood sugar. So if they're back to that normal level, they don't need any more, because if we do give them some more, we could actually put them into hyperglycemia. We could send it going too high. But if it's still below 80 after 15 minutes, they could probably benefit from another either half tube or whole tube, depending on their level of responsiveness. Okay. Root, oral, they need to intake it and swallow it. It does not work unless it is swallowed into the stomach. Actions, pretty simple, raises blood sugar. We all need a good level of sugar in our blood to keep going. It's what our brain really relies upon. If we don't have enough blood sugar, we get grumpy. And then if we are diabetic, we get to the point where we might go into a coma, which is really, really bad. So there are plenty of times you're going to show up on scene to somebody who is completely unresponsive. You're going to go through your assessment and you're going to have to kind of think, okay, trauma, cardiac, neurological, drugs, hypoglycemia, which one is it? And luckily, this is one of those ones that we can test for pretty easily. Get a finger stick on anybody who's altered, unresponsive after you do your ABCs, and it'll give you a really good number, right? So if that number is low, if it's hypoglycemia, great, you figured out the issue. If it's not hypoglycemia, great, you've erased something from your diagnoses, right? They're altered, but they're not hypoglycemic, great, throw it out. It's something else. Versus they're altered, it's hypoglycemia, great, let's call ALS, get them some sugar in their blood.
At what point do people become unresponsive typically? What level of blood sugar?
So it's going to depend on the person. And we tend to see alteredness happen below 60, but then really any time below there, somebody can be unresponsive. People's reactions to it really depend on the person. Like I have seen people who were like less than 15 who are unresponsive. I've seen people who were around 20 to 30 who were just kind of altered, who looked kind of drunk. And then it really depends. So anytime it's below 60, that's when we start to get worried. That's that real hypoglycemia, but it could range between 60 and 0 for them to go unresponsive. Oftentimes, even glucometers don't even read down to 0. If it gets below like 15, they just say low. It just tells you, oh boy, it's very low. And then glucometers tend to, depending on the glucometer, won't read past like 250 or 500, and it'll just say high. And so so if somebody's blood sugar is above 500, it could be between 500 and 10 million. We have no idea. It's just above 500 if it's that high. So it gives us the information we need to know, even if it's not a specific number, right? Like if it just says low and they're unresponsive, they need sugar.
If someone's
Yep, go ahead.
If someone's clearly suffering from hypoglycemia, but they when you take the finger stick, it's like 63. Would you say like just drink some orange juice, or would you still give this stuff?
No, that's a great question. So if somebody is a diabetic, they know that they have this issue, they're feeling off, you show up, they're like, I don't know what it is. I took my medication today, blah, blah, blah. You check their finger stick and it's 65. They're like, but I feel really woozy, like kind of gross. Like, I don't really know what's going on. Hey, you got peanut butter sandwich in the house? You want a glass of orange juice? I'll hang out with you for 15 minutes while you drink this orange juice. If you start to feel better after that, I take your finger stick again. It's above 80. Awesome. Let's take your vital signs. We'll get you to sign this piece of paper. Is there somebody here for you? These type of calls are really interesting. A lot of times diabetics know that this will happen, and it's happened to them quite frequently. I myself have been to a call where we show up, somebody is unresponsive in a chair, not responsive to pain, not doing anything. Their blood sugar read low. I started an IV. We gave them D10, which is essentially like saline water mixed with sugar. We gave them a whole bag. We were monitoring their vital signs, all that kind of stuff. They woke up after about 5 minutes. We hung out with them for about half an hour, checked their blood sugar every 15 minutes, got back to a normal level. I called the doctor. They agreed that it was okay to leave them there. Their family was there with them. If there was another issue, they'd call right back. So these are some of those calls where we might be able to work out a secondary treatment plan, or not secondary, like an alternate treatment plan for this patient. They might not need to go to the hospital with a little bit of correction. But if we got to the point where I was like, hey, you were unresponsive, this was really bad, I had to start an IV and give you medications that way, I would consider checking in at least with your PCP, right? We're never just going to be like, hey, yeah, sure, you don't need to go to the hospital, stay home, don't call us again, right? We're always going to vouch for them to get checked out. But whether that's by the emergency room, by us, or by their PCP, times where it's hypoglycemia, we can definitely have that conversation. Side effect of this is really bad taste. It's just like, these things are gross. It says lemon flavored, right? But it is not lemon flavored. It's just pure sugar. However, being from the great state of Vermont that we are, in Vermont, you can give 15 grams of pure Vermont maple syrup instead of oral glucose. That being said, if I see you in the ambulance wanting to give a hypoglycemic person Aunt Jemima, get out of here. It's Vermont pure maple syrup. Okay, no other state, no other country, Vermont, in Vermont. Support local. So yeah, there are plenty of like similar things like this from Vermont maple syrup that you can give to somebody. It tastes a whole lot better. It is a little bit more expensive to buy Vermont maple syrup for ambulances, but I think it's worth it. So that's just kind of a cool Vermont fact about running EMS here, is that we give people maple syrup instead of oral glucose. Does the same thing.
One thing I've like, my mom's a diabetic, and I have a bunch of it in my family, and I've noticed some stuff that we don't talk about when we're assessing patients is looking for medical bracelets and stuff like that that might lead to those that diagnosis.
Yeah, that's absolutely a valid way to determine what's going on, right? If somebody's unresponsive and you see that they've got a bracelet that has the Star of Life on it, usually in red, made out of metal, or a necklace that kind of looks like a dog tag, something similar, it will tell you type 2, type 1 diabetic, or, you know, I have this condition. Those are really good things to look for in our physical assessment. Not every person carries those if they are diabetic, but it's something to keep in your mind. If you see one, check it out. What does it say? In that vein, if somebody has a tattoo, unfortunately, that is not legal way of documenting a medical condition. So I don't care if you're about to do CPR on somebody and they have DNR written across their chest, until I see a notarized attorney signed, doctor signed paperwork, doesn't count. Same thing with like type 1 diabetic. That might spawn us to be like, oh, let's check a blood sugar, or oh, let's look for a medical tag. But I'm never going to say that person has a tattoo that says they're a type 1 diabetic. That means they're a type 1 diabetic. I used to work in the doctor signed the tattoo. That would be a first. I could see that. Yeah, I still wouldn't do it. But yeah, I was about to say, when I worked in the plasma center in Colorado, I saw some of the craziest tattoos, man. There was a guy with spider web inside his ear, face tattoos galore. And my favorite was this girl who came in and she had a massive, hyper realistic portrait of Ted Bundy on her arm. And I was doing her assessment. I was like, is that Ted Bundy? And she's like, yeah, oh, he's awesome. Like, I love him. I'm like, great. So yeah, you'll see some crazy tattoos. Doesn't mean they have a medical condition. Okay. Now we're going to talk about activated charcoal. So first off, this stuff is gross. It is essentially someone took a scooper. They went to a campsite, scooped up all the charcoal, blended it in with some water and put it in a thing and said, somebody takes medications that are bad for them, have them drink this. That's essentially all it is. So it looks like it, smells like it, and it tastes like it. It's gross. But National Registry says that we need to know about it, even though it's not in our protocols for Vermont. So the indications of this are if somebody has poisoned themselves, whether it's on purpose or by accident, by ingestion. So somebody has taken something in orally. Now, one of the reasons why we are not using it is because of how specific the terms and conditions are, essentially. Somebody would have to have taken a certain amount of pills within about half an hour of you getting there. And typically, if people end up taking a lot of pills, we tend to see them way after a half an hour. So the amount of times that we were giving this was super rare and super narrow that Vermont has said, we don't really need you to do this anymore. And essentially what it does is that it gets into those, it adsorbs those medications. So it coats the pills or whatever, and it actually stops the body from being able to process them throughout the digestive system. So if somebody had taken a whole bunch of, say, like acetaminophen or another like pill, it would actually stop majority of that medication from getting into the bloodstream. So it can have a lot of effect in stopping people from overdosing if they've taken these medications. But again, incredibly rare that we would ever end up giving this. If we were to give it 50 grams or the whole bottle, so one of these size bottles right here, and that means the patient needs to drink all of that 50 grams, whole bottle. So another one of the issues that we had with this was that, sure, you get there in time. Sure, you can confirm that they need it. All right, have them drink it without throwing up. If they throw it up, it's not doing the job of what it needs to do in the stomach. And it is very gross, and a lot of people will not take it down. It's an oral medication. They drink it. It adsorbs some toxins. So that means it doesn't absorb them. It just gets to one specific thing, doesn't absorb all of the material, just gets the molecules out of there. Bad taste, nausea, vomiting, side effects of this. Again, this is a good one to recognize and to know, but you are not going to be giving this in the state of Vermont.
So coming on scene with a patient who's overdosed, it's a transport only type thing if their airway is fine and they're breathing and they're so there's no treatment at that point, it's just transport.
Yeah, not for us as EMTs.
Okay.
If they took a whole bunch of pills like that, they need to get their stomach pumped. Essentially, we need to get them to the hospital quickly. Again, this is Vermont says no. So if you were an EMT in another state, there is a potential that this would be in your protocols. However, again, it's very specific protocols. Certain medications within a certain amount of time have them drink this, but no longer in our standing protocols. And so there are plenty of other issues that happen when somebody has taken medications to a high degree that we can deal with. Specifically, the instance I'm thinking of is when I was working at South Burlington High School last year, a girl came into the nurse's office with a friend who basically handed me an empty bottle of Adderall, long-lasting Adderall. It had been filled 2 days prior, and there were 90 pills in there at fill. And the girl said, I took the whole bottle. So she took roughly 90, essentially methamphetamine pills. So she started seizing due to the large amount of stimulants in her body. I wasn't even thinking activated charcoal. We don't carry it. It's not in my scope of practice, but I was managing the seizure and calling 911, not so much worried about giving her the activated charcoal. So there are plenty of things that are going to be an issue for us to even give them the medication. And we need to spend our time focusing on airway, breathing, and circulation management. So it's just that we used to have this in our protocol, but Vermont says, you know what, the amount of times we use it was not beneficial to the outcomes. So awesome. How is everyone doing? Anyone have any questions? Great. Our next one here, aspirin. This is a big one for us. This is a medication that, one, is easy to give. There's not a lot of contraindications. And two, we can give it if we think they need it. They don't need to be prescribed it. And three, it really helps people if they are in the situation of having a heart attack or having angina. This is one of those medications that is proven to increase survivability of heart attacks and other cardiac issues like that. So just like nitro, the indications here are cardiac chest pain. So we're going to go through that whole assessment that we would do for nitro to determine that it is cardiac related before we're going to give aspirin. They don't need to be prescribed it, so we can kind of just give it if we think they need it. The contraindications are not as severe or as stringent as nitro is. It's not very dangerous to people unless it's in like high doses. But we want to make sure that they don't have an allergy to it. They don't have a bleeding disorder like hemophilia, because aspirin stops clotting factor. So if they already have a bleeding disorder like hemophilia, it could be bad. It is also pretty strong and heavy on the liver. So if they have liver damage or we're convinced that they are a long-term alcoholic, they probably should not get it. It could be damaging to their liver. Or they've taken the max allotted dose for a day already. And a lot of people do take aspirin daily. It's kind of recommended by cardiologists. Take one baby aspirin in the morning every day. It will help reduce your risk of heart attack. So a lot of people hear that and they take a baby aspirin every single day. So that means if they took more than the dose we're allowed to give them, then they can't get any more. They already are at the max therapeutic level of that medication. So the dose for us is 324 milligrams or 4 81 milligram baby aspirins. So these pills right up here that come in this bottle, the chewable aspirin, 4 of these is our max dose. And unlike nitro, if we need to give somebody the max dose, if we want to give them all 4, we just give them all 4 right then. We don't do it one at a time like we would nitro. It is max out that dose as soon as we recognize they need it. So if they haven't taken any, we think they need it, give them all 4, have them chew it up and swallow.
And that's the max dose in a 24-hour period?
Yep.
Okay. So if somebody took aspirin at 10 o'clock yesterday morning and you get to their house at 8 o'clock the next morning, we can't give them any.
I would call medical control.
Okay.
Just be like, hey, wanted to confirm, I think they're having a heart attack or cardiac issue. They say they took 324 milligrams yesterday at this time. What do you recommend? Yep. But this also means that if they say, I took 1 baby aspirin this morning, that means we can only give up to 3. So we do have to do a little bit of addition and subtraction here. Oh, you've taken 3 pills today of 81 milligram aspirin. Okay, I can give you 1 more to complete that dose. The other thing that we want to consider here is that not everyone takes baby aspirin, and it is very easy to go to the store and get adult dose 324 milligram pills. So 1 full pill equals 1 full dose. So when we're asking somebody, do you take aspirin? We also want to confirm if they say yes, we say baby aspirin, like that's the small ones, the chewable ones, 81 milligrams. And if they say they're not sure, we want to look at the bottle to make sure that they haven't taken a full dose already. But for the most part, if somebody's taking this daily, it's low dose 81 milligram aspirin. Also, one thing that's a little confusing, which you might run into, is technically the max dose is 325 milligrams. But if you know anything about math, 81 times 4 does not equal 325. It is 324. They just were like, we're not going to make that minimal of a change to get it. 324 is good enough for our purposes. So if you see 325, that's technically correct, but the max that we can give is 324. Its route is oral, so that means this medication is chewed and swallowed. Unlike nitro, which dissolves under the tongue, this needs to get into their stomach and break down that way. And get ready for some crazy medical terminology. Its action is platelet aggregation inhibitor. So what that means is that it inhibits platelet aggregation. Did that help? So what that means is that the platelets in our blood, which tend to spawn clotting, are the things that make our blood clot, seal up our wounds and stuff. What this does when we give somebody aspirin is it makes the platelets essentially more slippery so that they will not stick together and that they will not form that clotting factor. So the reason we're giving that is because if somebody has a clot built up in their heart, right, in one of those arteries, this won't stop, or this won't make the heart or that clot any smaller, but it will stop that clot from getting bigger. So what this could mean is if we gave this to somebody at the right time, we could stop that artery from being completely blocked by that clot. We can actually stop that clot from getting bigger. Again, not going to make it smaller, but that's why this medication is actually preferred over nitro for cardiac instances, because this medication is actually doing something to prevent them from getting worse and not just mitigating their symptoms of pain. So that's why someone's having chest pain, we determine it to be cardiac. I'm going to say, great, take this aspirin. I'm going to consider giving nitro. We'll see how you do, right? Aspirin first, nitro after. The side effects of this tend to be GI stuff because it's kind of strong in the liver. It's also strong in the stomach. So we tend to see some like nausea, vomiting, maybe some like GERD or gastrointestinal reflux. So like heartburn or some stomach or intestinal cramping. Now, we also want to confirm with people if they say that they're allergic to aspirin, a lot of times they mean that they get one of these side effects. Aspirin is pretty rare to actually be like anaphylactically or truly allergic to it, but a lot of people have these symptoms if they take it. So if you really think somebody's having a heart attack and they need it, and they say, well, I'm allergic to aspirin, you can be like, okay, what happens when you take aspirin? And they're like, oh, well, I get a little acid reflux or like my tummy hurts. You can be like, okay, I'm going to give you this aspirin because you need it. But if they're like, you know what, I swell up, I get hives and I can't breathe, that's anaphylactic reaction. Don't give it to them. We just want to confirm because a lot of people will say I'm allergic to aspirin when they're really just thinking about the side effects that happen when they take it. So again, that platelet, right? The platelets are supposed to clot. They're supposed to stick together. They're designed to do that. So those white little things right there are the platelets covering up a wound. So they form a barrier. They get nice and solid to stop things from getting through. They will stop bleeding. And they're supposed to do that. But what they're not supposed to do, which they end up doing, is they stick to clots. So we've got our clot right here in this artery. And as those platelets are going by, they end up trying to clot and they get stuck around it and they make that clot bigger, right? And it gets to the point where it's actually increasing their chances of having a really bad response. So what the aspirin does is it doesn't take them away, but it makes it so the medication makes so the platelets actually aren't going to stick together and it'll stop that clot from growing anymore. Are there any questions about that? So another thing, just another consideration for aspirin, because it is doing this, it might make somebody bleed a little bit more than what's normal. So just keep that in mind. If they do have an open wound that is bleeding and they also are having a heart attack, right? We want to control that bleeding before we give them the aspirin. Okay, I have a quick question for you guys. Do you see that minnow fin? If you were to say yes, which I see some nodding, say yes, acetaminophen. So we're going to talk about acetaminophen, also known as Tylenol. It's the brand name. This is a medication that we're allowed to give now, and specifically, it is for non-cardiac pain. But we have some caveats here. Some issues with this is it comes into effect between 15 minutes and half an hour after you give them the medication. So depending on where you're coming from and depending on what is happening to the patient, it might be beneficial just to say, you know what, if you can hold off for 15 minutes to get to the hospital, they could give you something that might help your pain a little bit more versus me giving you this pill now and it only starting to kick in when we get to the hospital. It's not really going to help your pain in the ambulance. So that's just one of those things. But somebody who's having like ankle pain, they rolled their ankle, you've got a long transport and you've got a broken arm, maybe some acetaminophen is warranted. Its contraindications kind of similar to aspirin. It does have a strong kind of, it leaves a strong effect on the liver. And people can be hypersensitive to this, so they can be allergic to it. So we definitely want to ask them if they're allergic. Similar to aspirin, if they have a history of long-term alcohol abuse, or we are considering that they might have liver damage, we don't want to give it to them. And if they've had any other acetaminophen within 4 hours, we should not give it to them. The dose is up to 1,000. Pills tend to come in 250, 500, and 1,000 levels. I'm not entirely sure what they do in the ambulance. I think it's 500 or 250 pills. It depends on the service. It can be, so you can give up to 1,000. So what the math is going to depend on what size tablets you have. The route is oral. This is another one of those ones that they're going to have to swallow. So this is when we kind of get to that point where like, hey, we don't want to give them water, but we're giving them this medication to swallow. This is one of those only times that we can consider it. So that's going to lead us down that road of why are we going to consider giving them acetaminophen? Is there anything else going on? Will they potentially need surgery? Is this a wound that's like, I can't see? Is it abdominal pain? Is it cardiac? Like acetaminophen for us is like, we're going to have a long transport. Somebody has severe pain from a physical injury, swelling, anything like that. They have rolled, broken, something along those lines. That's when we want to give it to them. But we also want to consider, do we think they're going to need surgery, right? We don't want to give them anything to eat or drink if we think they're going to need surgery. So this might be another one of those times, hey, we've got a 45-minute transport. Somebody's got a broken leg. We're an EMT basic crew. I'm going to call med control. See, hey, they're in a lot of pain. There are no medics around. We've got a 45-minute transport and their leg is broken. Would you like me to give them some acetaminophen? And if they say yes, great, we can do it. They know the risks a little bit more of what they're going to need at the hospital. But for us, it's going to be one of those things where it's like, okay.
What is the processing time in terms of your body breaking it down and it no longer being in your stomach?
I'm not entirely sure, but up to 1,000 for 24 hours. Sorry, I should clarify that. So you can give them another dose of medication of acetaminophen up to 1,000 after 4 hours. So if they took like a 500 milligram pill 6 hours ago, you can give them another 500 milligram up to 1,000, but as long as it's more than 4 hours apart.
Right. I guess I was more asking because if you said you don't want something in their stomach for surgery, if you're a 45-minute transport, is it still, I mean, the effects of it start after 15 minutes, I imagine it's no longer sitting in your gut at that point, right?
Yeah, I'm not entirely sure on how quickly it breaks down, but it's not necessarily the pill that we're worried about. It's like the water, it's the excess just fluid, because anything that they can aspirate or throw up and then inhale is bad. And so any sort of fluid in their stomach, that's just like, we want to stay away from that, especially if they're going to need surgery. So these are one of the medications where we want to approach it with kind of a grain of salt, be like, okay, do we think the benefits outweigh the negatives, right? We're going to be in the ambulance for a long time. I don't think they need surgery. They're in a lot of pain. We can't get a medic. Great. Let's give you some Tylenol. But I'm like, when I was practicing 10 minutes away, I wouldn't really consider it. They get to the hospital, they'll have much better pain control, and the hospital can determine whether or not they need surgery better than I can. The actions of this one are actually kind of interesting. It's not completely known. They kind of are just like, yeah, it helps pain and reduces fevers. It's not an opiate. That's kind of what they say. It's just like, it's not completely known. It's classified as a non-opiate analgesic, a fever reducer, and it's similar but still distinct from NSAIDs like ibuprofen. So another thing that I want to clarify here is that its actions include being a fever reducer, but it is not an indication for us to give it to somebody. So we are not giving this for its action of fever reducing. We're not going to go to somebody who has a fever of 104 and say, here, take some Tylenol, because that's not what our indications are. That is just a side effect as far as we are concerned. We are giving it for pain. If it controls a fever along with that pain, great, but that's not why we gave it. Side effects, very similar to aspirin. These medications are really tough on the GI system. So nausea, stomach pain, and potentially a headache, maybe some cramping too.
Can you just review the dosing real quick? I got a little confused there.
Sure.
It's 1,000 that we can give them a whole 1,000 if they haven't taken any.
So similar to aspirin, like, right, it's up to 1,000 for 24 hours. So if somebody like aspirin had taken 181 milligram, we're going to complete that dose up to 4 pills versus acetaminophen, where if they have taken 500 milligrams, we can complete their dose up to 1,000.
So the contraindication, sorry, Connor asked this question in the chat too, and I was curious. Any other acetaminophen within 4 hours means as long as they haven't hit that 1,000 milligram max.
Yeah. So the reason we don't want to give more acetaminophen on top of it is because of how like detrimental it is to, or how harsh it is on the GI tract. So we can complete up to 1,000 after 4 hours. So if they have taken 500 milligrams, we can give them another after 4 hours. We can give them another 500, complete that 1,000. That 1,000 is for 24 hours. We want to give their body time to process the first 500.
But for the first dose, we can give up to a whole 1,000 in one go.
Yeah.
Okay, thanks.
Any other questions? Awesome. Oh, spoiler. Ooh, so this next one is a good one. Epinephrine, specifically epinephrine 1 to 1,000. So that 1 to 1,000 is its concentration. So there is another type of epinephrine that we keep on the ambulance. It's 1 to 10,000. So that essentially means like 1 molecule of epinephrine to every 1,000 molecules of saline or water. And so then the opposite would be 1 molecule of epinephrine to 1/10,000th of that in water. So the reason we give the 10,000 is for cardiac arrest. That is not within your scope of practice, but someone might say there are 2 types of epi on the ambulance. The type that you can give is this type, the super concentrated kind, specifically for anaphylaxis, which is major allergic reactions, a system-wide allergic reaction that could lead to somebody's death. Remember, anaphylaxis is one of those types of shock. So when the body is having an anaphylactic reaction, they are going into shock. They are in shock. So giving somebody epinephrine is one of those times, one of the only times that as soon as we recognize someone is in anaphylaxis, even if that means we come up, we do like 2 minutes of talking, less than that, we say you're in anaphylaxis, we give them epi. This is considered a life-saving medication in the right situation. This is an airway medication. This is an airway protector. If somebody is having anaphylaxis to the point where their airway is closing up, it will swell shut to the point where they cannot get air in. So it essentially becomes an airway obstruction. Their own throat is stopping them from being able to breathe. And epinephrine will open up that airway again. So if somebody is having true anaphylaxis, or we think that they're about to lose an airway, this is considered a life-saving intervention, and we can administer it in our ABCs if we have enough information to determine it's anaphylaxis right there. So this is one of those only medications that we can give before we take vital signs, depending on the situation. Contraindications are that they're not in anaphylaxis, or the medication is expired, or it looks gross. I don't know if you guys can see in this picture, but right here on this EpiPen, there's a little bit of a window, and that gives you a view of what the medication looks like. So if you're going to assist somebody with an EpiPen, take a look at that. Make sure you don't see any like floaties. It should be a pretty crystal clear color, but if it's like really brown, green, it's discolored, you shouldn't give it. That means the medication's bad. This is the first medication that we have, I think it's the only one, that determines dose via the age of the patient. So we do need to know 2 doses here. We need an adult and a pediatric dose. simple enough. Pediatric is half of our adult. So the adult dose is 0.3 milligrams. And for kids, it is 0.15.
And what's the cutoff for pediatric versus an adult? Is it 13?
So it's not an age range. It's kind of body development. So when we look at somebody who we consider to be on the line between like kid and adult, what we look for is signs of puberty. So on like a young male, if we see facial, underarm hair, pubic hair, that kind of stuff, tells us they're in puberty. We can consider them an adult. Versus for a female, it'd be something along the lines of like development of breasts, development of hips, if they've started their menstrual cycle, that kind of stuff. However, we also want to keep in mind that this is specifically for like EpiPens giving, and also we're going to draw it up, but this is something that we can confirm with medical control too. Hey, I've got a 6'5", 12-year-old boy, or something like that. I've got a very small 20-year-old female. Like, what would you like me to do? I don't want to give too much epinephrine. I don't want to, so we can talk about it. But for our EpiPens, they are pre-dosed to either 0.3 or 0.15. So if we are assisting somebody with an EpiPen, we go based off of what they have. We in Vermont don't carry EpiPens on the truck. And this is another one of those times where we kind of have to talk about what is national registry versus what Vermont says you can do. And we are teaching you national registry. And we are mentioning Vermont because we are in Vermont and majority of you will practice within the state. But an EMT class, we have to get you to the national registry in order to pass. So national registry says the only time you can give epinephrine is assisting somebody who is prescribed an EpiPen. And you can only assist them with their EpiPen. Even if you have an adult EpiPen on the ambulance, if it's not prescribed to them, you can't give it to them. So that's one of those first confusing parts. But Vermont says, as a basic EMT, once you get your Vermont license, they will teach you how to draw up 0.3 to 0.15 in a vial, from a vial, and give it intramuscularly in the deltoid. So that's the little bit of difference. Once you hit like advanced EMT, there is a specific algorithm to determine how much epinephrine someone gets based off of how much they weigh, but you guys aren't responsible for that. So if you are with an advanced provider and somebody who's in that kind of weird weight to age range needs epi, the advanced EMT or paramedic will take care of that. They will do that medication. But for your purposes, you either do 0.3 if they meet the criteria for an adult, or 0.5 if they meet the criteria for an infant, or not for an infant, for pediatric. This one is intramuscular. So it goes preferred into the lateral thigh. So that means the outside of the thigh. It's the big, thick muscle on the side. And we give that there because it's the biggest muscle we have. What if for some reason that person doesn't have legs, we can give it in the deltoid right here, or the buttocks. Those are two other options. But if they have a thigh, give it in their thigh. The other thing is, do I have one? I moved it, but I usually have a trainer EpiPen. So how we give it is also pretty important. On this picture right up here, you can see that it's got a blue kind of cap and that there is a orange needle cover. So the way that we think about this is blue to the sky, orange to the thigh. Plenty of people have taken off the safety and then pushed that orange button thinking that that's the button you push to inject the needle, and the needle goes through their thumb or injects them with epinephrine. So that's bad. So it is a click. It goes by pressure, not by like a button. So that orange part goes into the thigh, and you give it a good amount, enough to hear it click. And as soon as you do that, you're going to hold it there for at least 5 seconds. 5 to 10 seconds is preferred. That's because if you just like quickly administer it to somebody like that, all you have succeeded in doing is stabbing them. You have not given them any medication. So when you hear that click, hold it for 5 to 10 seconds to actually allow the syringe inside the auto injector to inject that medication. The way that I teach high schoolers about EpiPens is I say it functions very similarly. It's designed very similarly to a gun or a firearm. There is a safety, there's a trigger, and there is a projectile that leaves at fast speeds, which has a medication in it, and it can hurt you if you are in the way of it. So we need to keep these very carefully. We don't want to mess around with them. So there are plenty of times I've seen people messing around with EpiPens and oop, there it goes. There goes your thumbnail. Have a good time having an adrenaline rush. So be very careful with these. Its actions, there are actually two that we're concerned with. It is a vasoconstrictor. So it actually has an opposite response to nitro, which dilates the vasos. This constricts them. And it is a bronchodilator. So it opens up the bronchioles in the lungs. So if someone could wager a guess, which of these two actions are we most concerned with when we're giving somebody epinephrine for anaphylaxis? Which one do we care about the most?
The broncho, how do you say it?
Bronchodilator.
Are we worried-
Bronchodilator.
Aren't we worried about shock with anaphylaxis,
We are, yeah.
which would be vasoconstrictor, right?
So yeah. Yeah, it's a good question.
It seems like both, right?
So yeah, we are concerned with both. We do want to give it for both actions, but I would argue that we are more concerned with the vasoconstricting. Bronchodilation helps. People who are in true anaphylaxis, their lungs are closing, but the main issue that we tend to see why people die of anaphylaxis is one, they go into shock, because what anaphylaxis does to the body is it's actually the body saying, whoops, oopsies, my bad. It has an overactive immune response. So what happens is all of the vessels throughout our body just open up and they dump fluid specifically into like our face, our mouth, and our airway. So that's why people end up suffocating and dying, is because they get all of that fluid just accumulating really quickly in their airway, and it constricts. They go into shock. They lose their blood pressure. So giving vasoconstrictor is going to clamp up all those vessels, open up their airway, and then it's also just going to help open up the lungs. So both are really important, both really help them, but one is actually fixing that airway obstruction while one is just kind of helping airflow to the lungs. So again, I really like everyone's theories, but yes, vasoconstricting, one of the more important parts. We have other medications that are bronchodilators that we can help somebody who's having bronchoconstriction, but we don't have any other vasoconstrictors that will help somebody in anaphylactic shock. So side effects are side effects of an adrenaline rush. And if you've ever been super anxious and had adrenaline coursing through you without kind of like knowing why, it can lead you to feel anxious. So the side effects that we're going to see is tachycardia, so really fast heartbeat, and it could feel like their heart is beating really hard. They could be tremory, and they could feel some anxiety. Essentially, if you've ever had a really severe adrenaline rush, like you were driving your car, you almost get in an accident and you're kind of like, oh, whoa, what just happened? And you're kind of shaky, right? Or even if you've had like the good adrenaline rush, you went on a roller coaster and you get off and you're like, oh yeah, jazzy, right? That's what we're giving people. We naturally have epinephrine coursing through our veins all the time. Not all the time, but a lot of times. And so if we give somebody this fake adrenaline rush, essentially, they're going to experience an adrenaline rush. Let's see. So then last thing before we take a break, ready, check, inject is the Vermont protocol here. So you will learn how to draw up epi out of one of these using one of these. And you will draw up to that 0.3 or 0.15 to give to the appropriate patient. Part of the reasons we do this is one, EpiPens are very expensive. When I was working at the high school, I had like a whole bunch of different brands brought into the nurse's office by students, and I just wanted to see what they each cost. So this one right here, for a pack of 2, was about $500 per pack. It's $250 per syringe. The one below this, the really generic brand, was about $150 a pen. And then the step up above this, ones that are automated, like you pull it out, it tells you exactly what to do. That was about $600 a pop. So it's really expensive. Whereas these vials, $1.50. So it's much cheaper for ambulances to stock this than it is for them to stock EpiPens. So in a place like Vermont, where there are a lot of BLS first responders, and if we know anything about anaphylaxis, the quicker you can get there and give them epi, the higher chances that they will survive. Means that getting them epinephrine in this way is a cheaper and more effective way of saving people's lives. So that's why Vermont kind of does it. So this would allow people who maybe their main job as a first responder isn't on an ambulance. They're an EMT firefighter. And a lot of times maybe fire shows up before the ambulance can get there, or the first response gets there before the ambulance does. And they can administer epi, which is a life-saving medication, immediately, and then wait for the ambulance to show up for transport. So that's why it's such a big deal. But
what's the, is it the same injection site, or is it upper arm?
so it's preferred deltoid if we're going to use this kind of needle, but it's really any sort of muscle. So deltoid can go, and also lateral thigh. But the difference with this needle, I forgot to mention this, sorry. A auto injector can go through clothes, where this needle should not. This should be on bare skin. So it's a little bit easier to remove somebody's arm from their sleeve and give them a shot there than it is to just have them take their pants off to give them a shot in the leg, unless you're using like that auto injector. So preferred site for Ready Check Inject is this deltoid muscle right here. And once you get onto a service, or if you are already and you get your certification, your service will train you and get you all signed off. It is a per service training thing. We can teach you how to do it, but you need to get a sign off per your service to actually be able to do it. Okay, so that gets us to 7 o'clock. Why don't we come back at 7:15? And we will keep going. I got for acetaminophen. And I just wanted to make sure that I was telling you guys the correct information. And actually, it's a little bit weird. So I did some research online. I found a couple of different things. It's pretty standard that the max dose for an adult for daily 24 hours of acetaminophen is 4,000. But our protocol is the max that we can give is 1,000. However, one of the things that's a little weird, which I'm finding, is it doesn't say anything in our protocol book specifically about whether or not, if they've taken to 50, can we give up to 1,000? Let me read you what it says. So in our Vermont state protocols, these are of 2020, so they will be changing. They might be updated. But essentially for pain management, if we can't manage pain with ice packs or anything like that, consider, if not contraindicated, acetaminophen 325 through 1,000 milligrams per oral, no repeat. And that's all it says. But then in some the pearls, it says, consider not giving acetaminophen to patients who have taken medications containing acetaminophen within the past 4 hours. So it's weird. It's a little bit weird. So the way that I take that is, if they have taken, and this is what I was explaining to you. So if they have taken acetaminophen within 4 hours, we don't want to give them any more. But if they haven't, we can give them up to 1/4 of the max daily dose for an adult, which is 1,000, depending on their amount of pain. So that's one of those weird kind of things where it's just like, okay, what does this exactly mean? I just know that regardless of, and this is from a different kind of deal with medicine. When I was working at the nurse's office at South Burlington, acetaminophen was, if not the most requested thing, right? Kids always came in saying, I've got a little bit of a headache, and I have acetaminophen. And we're like, when did you take some? We didn't ask how much did you take. It was like, when was the last time you took any? And if they said anywhere within 6 hours, we didn't give it to them, even if they hadn't met that max dose. So that's the way that I'm taking it, is if they've had a medication with acetaminophen in it within 4 hours, we don't want to give them any more. But if they haven't, then we can give them up to 1,000.
Kevin, is that
Yo.
true for aspirin too? Because the aspirin max dose is also, I think it's like even like 6,000 milligrams per 24 hours.
It is not true for aspirin. For
Okay.
us, because we are giving it for cardiac reasons, it is 324, 24 hours.
So as long, if they've taken any, it's doing the platelet thing it needs to do, and they're done.
Yeah, if they've met 324 milligrams, we're not giving them any more.
Got it. Thank you.
Yeah. And I love stuff like this. So if anything that I say doesn't sound right, I am not 100% accurate on anything. I wouldn't say anything, but a lot of things, right? There are some things that I might have said wrong. So if something came out weird to you, question me about it. I will go back and look and double check, and we can have a conversation about it. That only makes both of us better, or all of us better, I guess. Awesome. Hopefully me sharing my screen does not kill this all again. Can still see and hear me. Great. Pop quiz. Did that just get you a little bit of epinephrine in your blood? I hope so. So I'm going to give you quick dispatches, just a little tiny bit of information about the patient. And I just want you to either put it into the chat or shout out what medication you think they need. Hold on, I can't see the chat, so.
I'll monitor it.
Okay. First one, 15-year-old male, confirmed peanut allergy and suspected peanut exposure, presenting with angioedema, facial swelling, difficulty breathing, and it reports it has only gotten worse. What medication does he need?
Epinephrine.
Good. Oop. Yeah, epi. Great. So we would see that. We don't really need to check his vital signs. He needs epi, life-saving intervention. Great. Awesome. Next one, 42-year-old female diagnosed with asthma, chronic bronchitis, and a myocardial infarction in the past. Difficulty breathing has been present for approximately 10 hours with no relief, even after she's used her inhaler so much that it is now empty. Inhaler is not expired. Her SpO2 is currently 80% on room air, and she is wheezing.
Oxygen.
Nebulizer.
Oxygen, nebulizer. Let's see. There is an asterisk there. We'll talk about it.
We can do epi for asthma.
There's an asterisk there. We'll talk about it. But yeah, so oxygen, definitely, maybe a nebulizer, but she's taken an albuterol inhaler so much all day, and it hasn't helped at all. Her SpO2 is still down at 80%. In advanced EMT and up protocol, it indicates that in this situation, she could benefit from some epinephrine. So not saying that this is in with your scope of practice to do, but recognizing that she might need a little bit extra help from somebody more advanced is definitely within your protocol. So with this patient, for you, you might want to consider calling advanced life support to come and give her epinephrine. Last one. 78.
Kevin, we're giving her O2 in the meantime?
Yeah, absolutely. So anyone who said oxygen, not wrong. You're totally right. But I was trying to trick you. All right, 87-year-old patient reporting a sharp pain in their chest along with difficulty breathing while gardening. They report a history of chronic obstructive pulmonary disorder, a cerebrovascular attack, and a myocardial infarction. You can hear her wheezing and they report a strange tingling in their throat. What medication do they need?
Oxygen.
Oxygen, yeah, that might help.
Epinephrine.
Yeah, you figured it out. Yeah, epinephrine. Reporting a sharp pain in their chest. No, it doesn't sound cardiac to me. With difficulty breathing that started while gardening. They have a history of COPD, chronic obstructive pulmonary disorder. They've had a stroke and they've had a heart attack. You can hear wheezing and they report a strange tingling in their throat. I would assess them for a bee sting. They're outside. I'd ask them about their allergies. But if they're having tingling in their throat and along with the difficulty breathing, that is some signs and symptoms of an anaphylactic reaction. So one of the things I just wanted to get across here is that not every patient who needs epi will present with the classic signs that we see. Oh, I got stung by a bee and I'm swelling all in my face. I need epi. Sometimes it's going to be kind of weird. But anytime that we're considering that somebody needs epinephrine, we need to know whether or not it's within our scope of practice to do. So the 15-year-old male and the 87-year-old female, definitely, but we would definitely need advanced life support to come for this 42-year-old female.
Kevin, on the line there where it's like you're not seeing any signs of like real respiratory distress yet, are you hitting them with epi right away as soon as you suspect, or are you waiting for symptoms to appear?
So in this patient, yeah, they do have some difficulty breathing and they're wheezing. So that tells us potentially that they are having that airway response. But yeah, right. If I'm just like, oh, you got stung by a bee, doesn't equal epi. It's like you got stung by a bee. Okay, let's do some assessment, right? It is
Well-
possible for somebody to have a reaction where they get stung by a bee and their hand swells, but they have no like airway response or difficulty breathing. That person doesn't need epi, that person needs Benadryl, which we can't give.
Right, but they're wheezing, I'm sorry, they have a chronic condition where they're probably wheezing all the time though. So how do you differentiate between that wheezing that needs epinephrine and something that is just a chronic condition that they live with?
For sure. Yeah. So that's when we'd ask about their allergies. We would do a physical assessment of like, do I see hives? Do I see swelling? Do I see a bee sting? You know, does this normally happen with your COPD that when you're gardening, it gets exacerbated? Like we are. So the whole thing here, I was giving you very minimal information, just trying to make a point that there is going to be times where they don't present normally. So you guys are asking all of the right questions. You're saying, what the heck? Why is that even the thing? I'm trying to read the chat here too. So that's a good question. So if you've got a 30-minute transport and somebody's like, I have an allergic reaction to bees, I definitely got stung by a bee, I'm having a little bit of difficulty breathing and tingling in my throat. To me, anytime that there's a confirmed exposure to an anaphylactic allergen and they have anything that's affecting their airway, it is beneficial to give epinephrine. It can change really quickly. For the most part, if somebody has an anaphylactic reaction that's really strong and it will affect the airway, it will do so very quickly. It's not going to be along the lines of, oh, you know, it feels a little strange. One of the times we might see this is somebody who had an anaphylactic reaction who received an EpiPen. We get there after they've received that EpiPen, their symptoms are diminished, but we start transporting them. Epinephrine lasts about 15 minutes in our bloodstream. So after about 15 minutes, they start to go back into anaphylaxis, but it's not going to present as strongly as it did before. They might start to feel some like weird tingling in their throat. So this has happened to me. Hey, you got an EpiPen. As soon as you feel anything strange in your mouth or your throat coming on, you got that EpiPen about half an hour ago, let me know, because that's a sign that it's likely you're gonna have difficulty breathing or lose your airway again. So those are all really great questions. And then why is Benadryl not in our scope? That's a great question. It's just not one that's in our scope. I could not tell you the doctor's reasoning behind it. Benadryl and epi for anaphylaxis is great, but as our role as EMT is really just that emergency response, what we care about is fixing the ABC problem, and then we can get them to the hospital. The hospital can take care of the Benadryl dosing, all that kind of stuff. We just worry about fixing their airway and then moving on.
If they're at home, like have taken the EpiPen, don't want to go to the hospital, would you recommend it? I mean, the way I also learned that thing Jesse was saying about like the point of an EpiPen is to get Benadryl on board.
Yeah, but that's not in our scope of practice. If somebody had taken an EpiPen for anaphylaxis, I would tell them epi lasts about 15 minutes. I don't feel comfortable leaving you. If I left, you could go back into anaphylaxis. Do you have another EpiPen with you? No, they also cost $250 a pop. You should come with us to get checked out. There's a lot of risks to staying. Just similar to what we're going to talk about when we talk about like Narcan and overdoses. Just because you are conscious right now and we have a medication on board does not mean it's going to wear off and you could die as soon as we leave. It's one of those things. We need to demonstrate all of the risks to them. You could go back into anaphylaxis and it could take us a lot longer to get back. And if you don't have that second EpiPen, it's really not safe. Yeah. So the point of us, get that epi on board so the hospital can get Benadryl on board. Or if you think they really need it,
Kevin, are we allowed to administer epi more than once if need be? Like say you're in, like I live in Underhill, it takes at least 40 minutes to get to a hospital.
Yep.
So if you see them starting to go back into anaphylaxis, we can administer more epi?
Yes, after
Okay.
15 minutes. And that's one of those weird things is because National Registry, we can only assist them with their EpiPen. So for the most part, if we're doing that, they're only going to have one. But in Vermont with Ready, Check, Inject, which we aren't teaching you technically how to do, after 15 minutes of their first dose of epi, if their symptoms come back, you can give them another dose.
Gotcha.
Yeah, great questions. All right. Moving on to Narcan. Narcan is a fantastic medication. It is a miracle drug. This is used specifically for opiate overdoses. It doesn't work for any type of overdose except for opiate medications. So that includes heroin, fentanyl, like codeine, Dilaudid, that kind of stuff. Hardcore analgesic medications, opiates. So that being said, its indications are the opiate overdose, which we can tell by what we call the opiate triad, which are 3 things which indicate that somebody is in an opiate overdose. I think I have a slide coming up which will demonstrate for them, those to you, but what they are is altered mental status, essentially unresponsive, pinpoint pupils, so pupils that are very, very small, constricted. They look as if somebody took a piece of paper, drew an eye on it, and then popped a tiny little pinhole in it. Very, very small, constricted. And the main one is decreased respiratory drive, not difficulty breathing, decreased respirations. So that's one of these clarifications. We are not giving people Narcan because they are on opiates. You will run calls where your patient is high on opiates, but that does not mean they need Narcan. The reason we give Narcan is specifically to raise their respiratory drive. When somebody is overdosing on opiates, it's not that the medication inside their body has little knives and it's going around ripping out their organs and stabbing them. That's not why they die. It is because the medication, opiates, are meant to depress the system, the central nervous system, to reduce the amount of pain that we feel. And they work incredibly well, too well. So when that amount of medication is in our bloodstream and in our body, it's not killing us. It is shutting down our respiratory drive so that we stop breathing. It is doing what it is supposed to do. That is what these medications are for. They are supposed to depress the central nervous system. But when they are taken in excess or they are abused, it can lead someone's respiratory drive to completely shut down, meaning that they will die of asphyxiation. Okay. So because they have opiates on board does not equal Narcan, but if they are overdosing and they cannot breathe well enough, that's when they need Narcan. We are giving Narcan to raise respiratory drive, not because they are on opiates.
Can you clarify the number of respirations? Is it the below 6 respirations per minute, or is it?
So it's going to depend, but for the most part, yeah, less than 8 ventilate is along those lines, right?
Okay.
So if you see signs of respiratory failure, so low SpO2, cyanosis, they're blue, very shallow respirations, any sign that they're just not getting enough oxygen, it's one of those indications. Now, we do have tools to help somebody breathe. We went over all of these on Saturday, airways and BVMs. So if for some reason we didn't have Narcan, it is totally acceptable to manage an opiate overdose, or not, I wouldn't say acceptable, but possible to manage an opiate overdose with an airway and a BVM. Because all that is happening in that person's body is that they're hypoxic and the drug is stopping their respiratory drive from working. So if we can give them high flow oxygen and effectively bag them and ventilate them, they also technically don't need Narcan. Narcan really helps though, because it will immediately raise their respiratory drive. One of the issues is it also raises their level of consciousness. And we'll talk about that a little bit. But dosing, this is another kind of confusing
part.
What
if, Kevin, what if they've stopped breathing?
If they've stopped breathing, we're going to assess for a pulse. If they don't have a pulse, we're going to begin our cardiac arrest protocol. In that, you can administer Narcan. So if you register somebody's in cardiac arrest and you think it's because they overdosed, we're going to work a cardiac arrest just how we normally would, but we can also administer Narcan within that. If they still have a pulse, but they are not breathing, we are immediately going to start bagging them and administer Narcan. So
can it be administered? It can be administered with the mask.
Yep, you just remove the mask and inject it up their nose. Essentially, you spray it up their nose. Yeah, it's a mist. It doesn't need to be like swallowed or anything like that. It just through surface area and contact with the inside of our nasal cavity, it absorbs and gets brought into the body that way.
Would you start compressions or would you wait?
I would compressions. Anytime somebody's in cardiac arrest, compressions start before anything else. Compressions are what saves lives. Narcan will help only if it's an opioid overdose. So unless you're 100% sure that it's an opioid overdose that caused the cardiac arrest, I mean, even if you are 100% sure, the first thing you're going to do is compressions, because you need to circulate the blood in their body for the medication that's being injected to actually get around to everywhere. And so when we start talking about cardiac arrest a little bit more, I'll tell you, essentially, if we are doing CPR on someone, we are preserving a corpse. Doing compressions is not what will bring them back. It usually is when they get defibrillated, but doing compressions is keeping their internal organs alive by circulating that blood. So if we don't do it and we just give Narcan, it's not going to fix their heart being stopped. But if we're doing those compressions and we're acting as their heart and we're circulating that blood and they're having an opioid overdose and we give them Narcan, it will potentially help them come back to life. But if we see somebody who's in cardiac arrest and we give them Narcan and we don't do compressions or don't do any other sort of CPR, it's not going to do anything. You are going to give that corpse a wet nose. So we need to combine all of our things. If somebody's not breathing, but they still have a pulse, start bagging them so they have some oxygen, and then give them the Narcan and continue to bag them until you see a change. So, doses of Narcan. This can be kind of confusing because there are 2 doses. The difference in the doses is the type of applicator you are using. So there are 2 standard types of Narcan applicators that we have. The first that I'll show you is the one that we tend to carry on the ambulance, and it looks like this. It's that one up top. So this is 2 milligrams of Narcan in here in 2 milliliters of water. The other one is this, which is 4 milligrams of Narcan, so double the Narcan, but in 0.1 milliliters of water. So this one has more Narcan per liter of water than this one does. So you can either give 2 milligrams via this one, or you can give one of these, which gives 4 to start. But the minimum you can give at a time is 2 milligrams. And the reason that we carry this on the ambulance versus what either lay people or like police or some fire services carry these is because this can be created or manipulated to go into an IV or an IO needle. So you create a syringe here with this. You can attach it to an IV line, or you can screw an atomizer on top and you can give it intranasally that way. Okay, so on ALS trucks, we carry this because personally, as an advanced EMT, I can give lower than 2 milligrams at a time. You guys have to give a baseline of 2. But if I was going to give someone Narcan who's truly overdosing, I'm probably going to give them 0.5 milligrams to start because I don't want them to wake up and go into withdrawals. I want them to have their respiratory drive to increase. So once you get to higher levels, advanced EMT and up, you can do something called titrate to response, which is give them a little bit of Narcan to try to help the respiratory drive. But for you guys, what you will have to do is you have to give 2 milligrams via this or 4 milligrams via this. Both are intranasal, and you can repeat up to 12 milligrams every 5 minutes as symptoms persist. So you can either give 6 of these every 5 minutes up to 12 milligrams, or you can give 3 of these. Now, Narcan in high concentrations can be an issue. It is a safe drug in low doses. If you gave this to somebody, if I took this right here, all I would get is a wet nose. And I would feel no difference in my body because I have no opiates in my system. This drug only affects opiates. It will not affect anything else. However, if somebody was to get a whole bunch of milligrams of Narcan in a short period of time, they could have a very bad issue, which is that their lungs flash flood. Essentially, they get a bunch of fluid into their lungs and it could lead to some severe issues. I'm very strong about this because I was on Colchester Rescue, and one night we get a call for an overdose, and we show up, and the guy was overdosing for sure. Very classic signs, wasn't waking up, and the cop was very nervous because he had given him Narcan and he still was not waking up. So when I showed up, I said, great, how much Narcan did you give him? And he said, I gave him 5. And I said, sir, you have these are 4 milligrams. You can't give him 5 milligrams. How much did you give him? He says, no, I gave him 5. He gave him 5 4-milligram doses of Narcan in less than a minute. Because how they were trained was someone's overdosing, you put this up their nose, squeeze it, and immediately they will wake up. That's not typically how it works. It's usually between 1 and 5 minutes. Okay, so he gave him 5 of these in less than a minute. So that guy woke up, went straight into withdrawals, which if you've talked to anybody who's been an opiate addict, worst feeling in the world. He nonstop projectile vomited for 30 minutes the entire way and spent a week in the ICU because they had to drain his lungs because of the reaction he had to Narcan. Okay, so it is a safe drug if you give it per how you're supposed to. 1 dose every 5 minutes per response. So if you give one of these, you do other things to help them, give them oxygen, breathe for them, whatever it is. And after 5 minutes, you don't see any response, but you're sure it's opiates, you can give them another one. Same thing, wait another 5 minutes, see if they come around, up to 3 times. If you exceed that 3 times, something is really wrong or they are on a very, very strong opiate. It is rare that that happens, but the opiate crisis in Vermont is only getting worse and drugs are only getting stronger. And there have been plenty of people in the state who need to be admitted to be on Narcan drips to get all the opiates out of their system. It can get really bad. So don't let me scare you with that. As long as you do not give the person 5 of these in under a minute, you should be fine. Follow your protocols. So either 2 milligrams with this or 4 milligrams with this. Now, another difference is that because there is more liquid in this one, instead of giving all 2 milligrams up one nostril, we're actually going to give 0.5 milligrams at a time up to 2. So pretty much 2 sprays in each nostril. So 5 milligrams, sorry, 0.5 milligrams, 0.5, 0.5, 0.5. 1 milligram in each nostril. And the reason behind that is because there's so much liquid that if you were to just squeeze all 2 milligrams up one nostril, majority of that medication would fall out in the form of just water and it wouldn't be absorbed. So by doing smaller spritzes, we're making sure that more surface area of the nose is actually absorbing that medication. Okay, so 1 milligram per nostril, 2 milligrams total at a time. That is a little bit confusing, so don't worry, we will review it quite frequently. The other thing about Vermont, Narcan is free in a lot of different places. You can go get this. Anyone over the counter can get this. You don't need to be an EMT to carry it. Before the pandemic, opiate crisis was looking a little better. After 2020, opiate overdoses and deaths have increased upwards of 40%. If you work on an ambulance in Vermont, you will see an opiate overdose. When I used to work in Winooski, it was a couple a week.
Is there research behind whether 2 milligrams or 4 milligrams is more effective? You know, that it seems strange that there are 2 different level dosage and it's not uniform just based on the, I guess, the company that makes the dispenser.
So 4 milligrams at a time will wake somebody up quicker than 2 milligrams would. But whether that's more effective, them waking up faster does not mean that it is better for them. One of the things, and when we talk about like the illicit drug lecture, I go into this quite a bit, but if we are waking people up who are really severely addicted to opiates and who are overdosing and we give them a bunch of Narcan, we are putting them in a really uncomfortable position. They feel like garbage and it becomes a lot harder to treat them. One of the things people say about Narcan, which is kind of misconstrued, it is accurate to a sense, but it's a little bit misconstrued, is that when you give Narcan, people become aggressive. That's not true. What happens is a rapid change in mental status from being super high to being super sober in a body that cannot tolerate being sober. And that's not a person who's just like, oh man, I can't tolerate being sober, like pass the joint or whatever. It's when they are sober, when they don't have opiates in their system, they want to die. They feel so sick. So just imagine you go to bed, your normal routine, right? You've maybe like a glass of wine in, you're like super warm and comfy in your bed. It's cold out, but you're nice and soft. You fall asleep. It's the best sleep you've ever had. And then you wake up to a bunch of people in uniforms. You're laying on the bathroom floor, naked, cold. You feel like you got a flu and you're going to throw up and your nose is wet. I'd probably be a little aggressive too. So that's the difference. And so if we're giving people a whole bunch of Narcan really quick, we are forcing them to feel like crap, and they will not like that. And chances are they have been down this road a bunch of times and they're like, screw you. I don't want to do this anymore. Get away from me. You gave me Narcan. You ruined my high. I'm going home. So purposes, it wakes people up really well. So for lay people and people who may not be trained, right, giving them this will save their life. For us, especially at the advanced EMT level, I know that if I give them a whole bunch of Narcan, they will not cooperate. They will likely feel like garbage. They will not get good treatment. So I will give them just a little bit, enough to get their respiratory drive going, to make sure that they will get to the hospital alive. And then I'm going to leave them in a nice warm bed. I'm going to leave, and then they can get the treatment they need without necessarily being thrown right into withdrawals. If they get enough Narcan where they can happily sleep off their high and wake up and live their life the next day, that's what I prefer. And again, we're gonna go way into this when we start our illicit substances lecture.
What's the respiration rate that you're targeting to know whether or not to administer another dose?
So back to normal, essentially. Like they have a high SBO, or like a normal SBO2 with a normal respiratory rate that is deep enough. But essentially looking for it to get back to normal. Unfortunately, because we're going to give, like, you have to give minimum of 2, you're likely going to see just mental status change to the point where they can manage their own airway. But for our purposes, if it goes from too little to just enough to perfect, that's what we're looking for.
So on that AVPU scale, are you looking for them just to get barely back to verbal, kind of? Is that what you're saying?
I don't necessarily care about the AVPU scale. I'm more concerned about their respiratory drive. If I can get their breathing back to normal without waking them up, primo, but that doesn't really happen very often. They will likely wake up and be able to get their breathing back on track. It's also pretty normal that somebody who's overdosing could just need some oxygen. There've been a couple times where I've shown up, somebody's been definitely on opiates and overdosing, but their breathing rate wasn't so low where I was like, they need Narcan right now. So I opened their airway. I put a high flow NRB on their face. About 2 minutes later, they woke up super intoxicated and high, but I didn't need to give them Narcan. I woke them up. We brought them to the hospital and they got help there. So as long as you are treating the issue, the breathing depression, you can treat that however you want. But typically, if we're going to overdoses and it's severe, airway, breathing, circulation, Narcan.
What was the breathing rate in that situation?
I can't remember off the top of my head, but his SpO2 is probably, I think it was like 95. He had some cyanosis and he was breathing deeply, but kind of slowly. So I don't remember the exact number. It was probably between 10 and 8. And so I was like, I'm going to give him some oxygen. One of the things was, it was a weird house to get into. So I went ahead with a partner. It was very small while the rest of my crew brought the stretcher in. And so I just had the oxygen bag. So I was just getting him set up, doing airway, breathing, circulation. And I was like, we're going to need some other stuff. I'm going to get him the oxygen he needs while I wait for my crew. A couple minutes later, before they got there, he started rousing and like woke up. And I started my assessment and he was obviously intoxicated, but I didn't need to give him Narcan. Okay, so route for Narcan, intranasal. So the only way that you guys can give it is up the nose. Very simple with this one. You just insert this side into the nostril. You press the button, it'll happen. Versus this one, you do have to read the markings on here. You can see that. To give, it's 2 milligrams per vial. This isn't full, and that's just water. It's not real Narcan. But you attach it to this. You remove the cap from here and a cap from here. You screw them together. You'll remove this cap, and I don't have one, but you put a nasal atomizer on it. So you can see in this picture right here, that kind of a conical thing, you put it on. And then when you squeeze the syringe, it turns it into a mist. You do 0.5 in each nostril up to 2, or till you get to 2. The actions of this is where that antagonist vocab comes into play. This is an opioid antagonist. So it's fascinating. It goes into the brain. It binds itself to all the opiate receptors that we have, and we have naturally occurring receptors for those drugs. It sits itself in there, and it knocks the bound opiate off of it, and then it blocks anything else from coming in. So if any other opiates try to bind to the receptor, it stops it. So it essentially mimics an opiate and then stops any others from binding. So it completely reverses the effects of opiates in the body. It's fascinating. However, some side effects, it can cause vomiting due to having the patients go into feelings of withdrawal. It will cause a rapid change in mental status, which often results in aggression, but it does not cause people to be aggressive. If that was a true side effect, if I took Narcan, and I didn't have opiates in my body, there would be a chance that I would get aggressive. And then in high doses of it really quickly, we have the chance of flash pulmonary edema. So really quick lung swelling. Now, I did put an asterisk next to the opiate antagonist because technically this is still debated upon. You will pass a test if somebody asks you what to classify Narcan as and you say opioid antagonist, but just for your own awareness, it's still being debated upon in the medical community. It's also known as an opioid reverse agonist because it doesn't meet all the criteria for both. It is that interesting of a drug. But that's just for your awareness. If you study that it's an opiate antagonist, that is good. Awesome. So here's a diagram of what it does. It's really cool. It gets in there, it physically stops the medication from having any place. So that opioid is still in the body. It's still circulating the system, but this medication, the Narcan, does not allow it to actually take hold. Again, it can wear off. Narcan, similar to Epi, lasts about 15 minutes. So if that opiate was strong enough and there's a high enough concentration in the body, it might not work with just 2 milligrams. Or if it did work with 2 milligrams, they could go back into an overdose. They could lose their consciousness again and start not breathing well enough. So keep that in mind. It is incredibly common for people who are given Narcan for an opiate overdose to wake up on scene and say, howdy doody, thank you for the help, goodbye. I am not going with you. I'm not telling you any information about myself. Have a good day. And walk away without any regard or care for paperwork or anything like that. There are also plenty of times where the person will just say, you know what, I don't want to go with you. I do this all the time. This is like the 5th time I've been Narcaned this month, right? So what we have to say and what we can do is we can say, you know what, I appreciate you saying that. Like, I know that you know what you're doing. However, from what I know, Narcan can wear off. And if you still have the drugs in your system, there's a chance you will go back into an overdose, and I will not be there this time to bring you back out. So we do want these people to go to the hospital, but they won't. Not all the time. And if they are conscious, alert, oriented ×3, even if we did give them Narcan, we can't force them to go. There are some areas, I know that Winooski, the police have a policy that if you are awoke by Narcan, by a first responder, they will require you to go to the hospital. They will not allow you to cancel. So like they will put you into protective custody and bring you to the hospital. But not everywhere it does that. And it's very common for people who get Narcan to not go to the hospital. Chris and I were on a call where we went to an overdose. It was in Winooski. We showed up. This poor woman, her dealer overdosed in her house. And the police were doing a great job of keeping him alive. And they realized that if they stopped giving him painful stimulus, so they were doing a sternum rub, he stopped breathing. But when they were doing the sternum rub, he was breathing just enough for him to like stay not blue. So this woman, this police officer, had leather gloves on. He didn't have a shirt, and she had been doing a sternum rub for about 10 minutes to keep him conscious enough to keep breathing. And so when we arrived, he had just like a red, no skin, raw right on his chest from how long she had been doing it. We get up, we start managing his airway. I start a line. I give him probably about a milligram of Narcan. We start just managing his airway. A couple of minutes later, he wakes up, takes off the oxygen mask, looks down at his arm, calmly takes out the needle, holds his arm, says, "Thanks, guys. See you later." So we try to talk to him. We try to convince him. Nope, not going. All set. Thank you. As he's walking out towards, "Sir, please let us at least check your vital signs. Like, you just were very close." "Nope, all set. Thank you." Dripping blood off his arm. 2 police officers there. "Bye. Bye, dude. Maybe see you later." Happens all the time. Keep that in mind.
I know some departments, like our department has a leave behind bag for people who don't want to go to the hospital.
Yes,
Narcan in it and references. Is that a standard protocol in Vermont?
absolutely. That was the next thing I was going to bring up. So because this is such a common thing where people don't want to go, we've started this policy where we have Narcan kits that have Narcan like this in it, easy for lay people to use, and it also has resources for help, for opiate addiction, all that kind of stuff. Totally acceptable. You give someone Narcan and they say they don't want to go. Great. Well, I'm going to leave this in the care of your friend. I'm going to give you this. If you need this or your friends need it, give it to them and call us. Right? We're not police. We're not there to get them in trouble. We are there to make sure that they keep breathing. Even if we do it 500 times. So here's that opiate triad. Altered mental status. So it could range from being lethargic to sluggishness to complete unconsciousness. If they are truly overdosing and need Narcan, they will be unconscious. They will be unresponsive. They will have pinpoint pupils. So they will look something similar to this. And their respirations will be decreased. So if they have all 3 of these things, it's pretty much confirmed that they are on opiates. They're overdosing. If they just have altered mental status and pinpoint pupils, that kind of just tells you that they're on opiates, but they're not overdosing. It's when they don't breathe well enough that they're really, really overdosing. So if you're ever talking to somebody who just kind of seems drunk or tired or kind of sleepy and you look at their pupils and they're super small, they're probably on opiates. Now, overdoses do not just happen to addicts. Couple different times, gone to either nursing homes or the one that I'm thinking of. We went to a non-English speaking house in Winooski. This grandmother had just gotten surgery. And from what we could discern from the family, she wouldn't wake up. She went down to sleep, could not wake up. She was turning blue. We got there, we did an assessment. We checked out her pupils. We said, "What medication is she taking?" They handed us a bottle of opiates. We gave her some Narcan. She woke right up. What had happened was a little one side effect of, age, but also opiates is a little bit of memory, forgetfulness. She woke up that morning, was in a lot of pain, took her opiate medication, went down for a nap, woke up, was in a lot of pain, couldn't remember if she took it that morning. She had just taken a nap, so she was like, "I just woke up." She took another one, made her sleepy, went back, took another one, and she ended up overdosing by accident. So keep that in mind. Don't just assume that you have to see heroin needles and paraphernalia for it to be a drug overdose or an opiate overdose. A lot of times people will begin their descent into opiate addiction via completely legal prescribed opiate medications. Any questions about Narcan before we move on? Awesome. Next one, very exciting, also a really great medication, is albuterol. This is another medication that we will talk about the difference between National Registry and Vermont. I'm always going to start with giving you the information you need to know to pass the National Registry test. So we're going to talk about that, and then we'll talk about Vermont. So albuterol, the indications are difficulty breathing, specifically the type that we can assess wheezing with. So bronchospasm or constriction just means that the bronchioles in the lungs, those tubes, are getting small and constricted. So when that happens, we hear the telltale sound of wheezing. So let me see if I can do it. Right? That was just me forcing air out of my lungs. But if somebody is taking a deep breath or breathing and you hear that with expiration or inhalation, that tells you that the bronchioles are constricted. Now, albuterol won't help if somebody is having difficulty breathing that is not related to bronchial constriction. If somebody just ran a little bit and they're out of breath, or something else, they're having a pulmonary embolism, it's not going to help. This is only good when their bronchioles are constricted. And for us to determine that, we have to be able to hear audible wheezing with our ears. You guys as basic EMTs are not allowed to take a stethoscope and listen to somebody's lungs and say, I hear wheezing. It's a little weird, but it's true. You guys are only allowed to determine presence and a quality of air leaving and entering the lungs. But if you hear somebody wheezing audibly, like you can just hear it with your ears, you can say they are wheezing, they need albuterol. This is another thing similar to EpiPens, how National Registry says you can only give somebody albuterol if you are assisting them with their own metered dose inhaler. So if they have a rescue inhaler like this red one up in the corner, if they are prescribed that and it's within date, you can assist them with it. That's what the National Registry says. Contraindications of this is they are not having wheezing. They're having difficulty breathing, but is not due to wheezing, or you can't hear it audibly. We're not going to give it to them. Also, if it's not theirs. Now, dose, you will get confused on this because Vermont also allows you to assist with a metered dose inhaler, but has a different dose. So we're going to talk about National Registry. So National Registry says one dose is 3 puffs with a spacer if available. If not, that's fine. 3 puffs of the inhaler. And you can do that up to 4 times. So a total of 12 puffs. Vermont says 2 to 4 puffs while symptoms persist, or a nebulizer treatment. But for National Registry, 3 puffs 4 times. The route is inhalation. And the actions is it is a bronchodilator, but I did put a clarifying term there. It's a very hard word to say, sympathomimetic. What that means is a bronchodilator that is occurring because we are stimulating the sympathetic nervous system. So we're actually stimulating that fight or flight response. So albuterol actually spawns a little bit of epinephrine to be released into the body, which is one of the reasons why it has such a strong bronchodilation. But that being said, we are stimulating that sympathetic nervous system. So some of the side effects are going to be very similar to epi. They're going to have an increased heart rate. They're going to feel kind of anxious, and they will have some tremors. But this works really well. Plenty of people are prescribed inhalers, whether it's for asthma, whether it's for COPD or some other condition. If they have it, they likely will know how to use it, but you're happily able to assist them per National Registry. Now, for Vermont, we are going to talk about that because it is a bit different. In Vermont, we can actually give them albuterol even if they are not prescribed it. As basic EMTs, you guys can do that. We can give them what we call a nebulizer treatment. Do I have it up here? I don't. So with that, we will give them one of these little Kool-Aid. Remember those old wax Kool-Aid things you twist off the top and you can drink out of them like that? It's very similar to that. So it's a small wax tube. You're going to twist off the top, and then you're actually going to squeeze that liquid into a nebulizer, which attaches to a mask. You put it onto oxygen, put it around 6 to 8 liters, and it will nebulize into like a mist, and that person will breathe it in, and that's how it helps. So Vermont, pretty liberal with the amount that you can give. You can give people Albuterol, just albuterol, 2.5 milligrams, while symptoms persist. So if someone's having really bad difficulty breathing with wheezing and you're half an hour out and they say that the albuterol is helping them, but the symptoms are still persisting, you can technically give it to them the entire way. They can keep refilling it as long as it's just albuterol. However, I will caution you, there are some patients you want to be considerate of with this. Specifically, that one on the pop quiz. She had been taking her albuterol inhaler for days and it was not helping, so much to the point where she used it all and she was having difficulty breathing still with wheezing, right? That tells us the albuterol is not helping. She might need something else. Also, depending on the patient, and I have had this patient and I called medical control just to be sure, but we picked her up from an urgent care, similar to that one we were talking about. She was, I think she was 98. She was like 80 something pounds. She had been having wheezing and difficulty breathing for like a week. She had used her inhaler and we got her in the ambulance. They had her on a nebulizer treatment throughout all of urgent care. When we got her in the back, I checked her pulse and it was close to 200. It was like 188. And she's like old and very thin and tiny. And she was having major difficulty breathing with wheezes. And so my crew was like, we should give her more albuterol. And I was like, albuterol affects the sympathetic nervous system, so her heart rate is going to go up. Her heart rate is 180 plus. I don't feel comfortable giving her more albuterol, even if she is having difficulty breathing. So I called medical control and they said, yeah, don't do it. You're right. Don't give her that albuterol. If she's been taking it this long and it's not helping, she needs something else. Get her oxygen, get her here. So keep that in mind. While that isn't technically one of those contraindications, we do need to critically think about what our medications do to our patient and what our patients are able to withstand. Typically, people who are elderly cannot withstand a heart rate that fast for very long. It could lead to their death. So keep that in mind. Critical thinking, very important, but that was one patient out of dozens, if not tens of dozens that I've given albuterol to. So the difference is, right, when someone's having bronchoconstriction, it's when that their open normal airway, where I'm breathing, you can hear the air going in and out, but you don't hear any resistance, you don't hear any high-pitched whistling, versus what they look like in an asthmatic airway during an attack or COPD, something like that. So what the albuterol does is it makes, or hopefully will make, a constricted bronchiole that looks like this back to close to normal. So that's the whole point of it, getting it down into the lungs to open it up to reduce that wheezing. Now, this medication is only for Vermont. So we will not really be testing you on this for national registry standards. This is for your knowledge about Vermont. Because Vermont is pretty liberal with our albuterol, they also give you the opportunity to give what we call a duoneb. So that is two medications, albuterol and Atrovent or ipratropium bromide. I just call it Atrovent. And it's for a very specific reason. While albuterol is for bronchoconstriction, what Atrovent does is dry up the lungs. So if we hear wheezing, audible wheezing, and they're also like having a productive cough, and you can hear just liquid in their lungs, that's a sign that they should get a duoneb, because in conjunction with opening up the bronchioles, it will also dry out some of those secretions, making it easier for them to breathe. If they don't have any wet lung sounds, or there's no evidence of secretions, or they're allergic to it, don't give it, but those are the main contraindications. We're going to mix this in with our 2.5 milligram nebulizer, albuterol, and we're going to give 0.5 milligrams of ipratropium. It comes in the same form of that plastic tube that we can squeeze into there. However, a lot of ambulances will carry albuterol and duoneb package. So it's just one vial that has both ipratropium and albuterol in it. Not a lot carry albuterol and ipratropium. Some do, but there are, I think on the albuterol slide, this is actually a duoneb. It's that purple and blue, whereas albuterol is just blue. So it'll just be one thing with 3 milliliters of water and 3 milligrams of medicine in it.
Kevin, do you know if some services carry albuterol and duoneb?
Yeah, they should. So most services will carry just albuterol, but then also duoneb things, because you can give essentially, I wouldn't say unlimited albuterol, but you can give a lot more albuterol. There's not really a limit on how much you can give, whereas you can only give 3 duonebs. So they won't just allow you to only have duonebs on there. It'll be duoneb or ipratropium and albuterol, but you should always have just straight up albuterol for those nebulizers.
Got it. Thanks.
Yep. Root inhalation, it's the same thing as a nebulizer, goes in with that albuterol. It's an anticholinergic, parasympathetic, something like that. I tried to. Parasympathetic. And it reduces secretions in the lungs. That's the big deal. If we hear liquid along with that wheezing, we want to dry it up a little bit, open up those bronchi. Side effects can include dizziness and nausea.
Is it only given through a nebulizer? Does it versus like an inhaler?
Yeah, if there were inhalers of it, it's not within our scope to assist. For the most part, it's always going to be in our duoneb.
Okay.
I'm not sure if they make just ipratropium inhalers. I bet they do, but not that we get familiar with.
Okay.
So yeah, just nebulized for our purposes. And you can give 3 duonebs total. But you can repeat them one after another while symptoms persist, up to 3 times. But you can repeat just albuterol as much as you want. So you could give 3 duonebs and then continue them on a nebulizer with just albuterol as long as you do not make it that duoneb, as long as there's no ipratropium in there as well. So here are the devices, the nebulizers. So they look like this, and it's this capsule right here that you're going to unscrew, and you squeeze the liquid into it. The tube connects to the oxygen tank, and then you pump the oxygen through here, and it makes a cool, like hissy bubbly sound, and vapor leaves. And then either you can have the patient hold it in a mask and breathe that way, or you can have them hold this T tube, which is kind of like they can hold it, and there's a mouthpiece, and they can breathe out. It's really more so what they're comfortable with. Some people really hate having the mask on their face, and they would much rather like control when they take the albuterol inhaler, or just, I mean, the nebulizer. But then some people like the mask where they can just continuously breathe it. Oh, and this is only for adults too. Duonebs for adults only.
How long are they supposed to hold their breath in?
It's really not holding your breath. It's just take a nice deep breath in and then exhale. You're trying to get it as deep as you can. Holding it is hard for them, might not help. So just have them take as deep of a breath in as they can and exhale normally. You want to walk them through breathing slowly. A lot of people who are having this difficulty breathing will be. So you want them to breathe slowly so they get it deep into their lungs where it's actually going to help.
Kevin, for either of these medications, is there an option for somebody who had an asthma attack to the point where they're no longer breathing? Like with the Narcan, you can give it even in cardiac arrest. Is there anything like that with this?
Not with this, because they need to be able to inhale. We don't have a device that can like legitly, without being kind of sketchy, force air and medication down into the lungs if they're not breathing. We can't attach this to a BVM.
That's where I was going, does this, yeah, got it.
Yeah,
Thanks.
It wouldn't help in that situation. In that situation, in cardiac arrest now in Vermont, we actually really don't put a lot of emphasis on breathing for them. It's all compressions and use of AED and stuff. It's a good thought though. That actually brings me to another point, is that this isn't a skill for you, a CPAP, but you can line, or you can put a nebulizer in line with that CPAP. So if someone's having that difficulty breathing and they need some albuterol, you might be asked to set that up for somebody who's getting a CPAP treatment from an advanced provider. Okay, last couple of things here, guys. This one, keep this in your mind. This is a good mnemonic for poisoning and stuff and overdoses. but we'll talk about these organophosphate nerve agents pretty quickly. So sludgem, salivation, excess salivation, lacrimation means watery eyes or crying, not necessarily like someone sobbing, but just uncontrolled, their eyes are watering, they can't figure it out. Excessive urination, excessive defecation, general GI upset, so cramps, nausea, vomiting, evidenced by this emesis, vomiting. And then meiosis is constricted pupils too. So if they have any of these things or all of these things, that is a pretty straightforward way to tell that they have been poisoned by a nerve agent or just poisoned in general. So the reason we talk about these is because these nerve agent injectors actually become part of our scope of practice in the event of a nerve attack, a terrorist attack, or just something like that. So if it was determined that there's a mass casualty incident due to a nerve agent or biological weapon, FEMA and the government will bring these to you and they will give them to you and say, use them on the patients. So they become part of your scope of practice, but only in that certain section. And so the two that it could be are atropine and 2-PAM chloride. We're not going to have to know a lot about these. Atropine increases the heart rate, it dries up secretions, and it helps with gastric upset, whereas 2-PAM chloride reduces muscle twitching and helps with difficulty breathing. So those are the main reasons that people will die from nerve agent poisoning. And so we give them in this 1-2 auto injector. It's kind of like an EpiPen. We just remove the safety, inject into the thigh, and then we do number 2, remove the safety, inject into the thigh. Hopefully we will never have to do this. This is only in the case of a massive MCI due to a nerve agent attack, but it does become part of our protocol once FEMA says so. And then these will be distributed to you. You don't have, your services aren't required to buy them or keep them up in stock. There's stockpiles all across the country, and if we need them, FEMA brings it to the place that's been affected and provides it to all services and providers. So just keep it in mind. The main thing we want to remember from this is this acronym. The sludgem will help you determine if somebody's been poisoned by something. All of these are really signs that the body is just trying to get rid of excess things. So salivation is trying to get rid of all the excess, but through our saliva, excess through tears, excess through urination and defecation, and excess vomiting, that kind of stuff. It's really showing that the body is struggling to get rid of stuff. Other than that, guys, that is all of pharmacology for the EMT. It's a lot of information. And just so you guys know, it only gets easier once you keep practicing and you get studying. These are, the slides that we are going to have to memorize. We do need to know all of that information about each drug. In order for us to declare you competent as an EMT, we are going to have to hear you from memory without notes say all of that stuff about the medications. These medications are very important. Our knowledge is very important for being EMTs. We need to know the ins and outs of all of the drugs we can give, why we're giving them, what we're looking for, why we would not give them, how we give them, and what we are expecting to happen.
I have a question about when you give glucose. You mentioned if they're hypoglycemic and we give them glucose and then they're better, would they have to suggest that they don't go to the hospital? We can't say, you're good, we're not taking you, right? They would say, I feel okay. Okay.
Yeah,
but we
for
would,
the most
we
part,
wouldn't,
that's the only reason.
Yeah, but we wouldn't bring that up, right? That's totally on their conversation side, not ours.
Yeah.
Okay.
We're always going to recommend someone get checked out at the hospital, even if we don't think they need to. So yeah, guys, also all of these slides are on J&B. They should look exactly like this. If you go into the resources tab, all of the PowerPoint should be in there. So you can see all of this stuff to review, but I will share my screen once more so you can finish that sludgem.
Do folks have other questions for Kevin?
Oh yeah, sure. About the exam, what chapters are covered by the exam?
The ones through last week.
So that'll be all chapters 1 through 10.
Yeah, the stuff from tonight isn't on it.
I see. So that'll be every single chapter, like 1 through 10.
Yep.
All right, thank you.
Yep.
We have how long to take the exam? Like not time wise, when is the test available until?
It's available until 23:59 hours on Sunday night.
Okay. So this week.
Yep. Yep.
Okay.
Yep. You have to take it in one sitting. So you have 2 hours to take it. And that's more than enough time. It's only 50 multiple choice questions. So you have plenty of time to take it. But if you don't take it while you're on duty, because if you take it and you go on a call, it will time out. So just kind of keep that in mind. You have to take it all in one sitting.